encompasses every single organ system in terms of its involvement. I'm deeply grateful for all the esteemed faculty and moderators who had graced the occasion, and very thankful for Dr. Nageshwar Reddy and the administration for making this possible, because without which this cannot move on. May I request Dr. Nageshwar Reddy to give the introductory remarks, please.
Thank you, Dr. Nasim, and welcome to this unusual meeting on sarcoidosis. I think I must congratulate Dr. Nasimam and the team for being actually courageous enough to take up this topic, because one, as you said, there are a lot of uncertainties, not only in diagnosis and treatment, but also uncertainties in everybody's mind, so that sometimes some difficult topics people don't want to really get into because they're best left unsaid. But so I think it's your not only your involvement in this, but the cardiac sarcoidosis, for which you are a world authority, which I think to a large extent makes this a very important area. I think sarcoidosis, like you said, affects everything right from the eye to the lungs to the GI tract, heart, and so on. So it's like universal, and a departmental meeting like this is extremely helpful for the physicians. I'm sure there are many online physicians now watching this program. Will be extremely helpful to them, and I'm sure this will be a very productive academic session. Thank you very much.
For those kind words. With this brief introduction, we will now begin the scientific session. May I request Dr. Varaprasad, who is the MDDM Rheumatology from NIMS, APLAR Fellow, previously Associate Professor of NIMS, and currently Consultant Rheumatologist at Yashoda Hospitals, Hyderabad. He is also the Associate Editor for a few journals, and he has also been the Scientific Committee Chairman for National Rheumatology Conferences. We will be joined soon by Dr. Rajkaran, who sends his apologies as he is currently running late. Dr. Varaprasad, sir, you can kindly start off this first sessions.
Thank you, Dr. Madhuri. At the outset, I would like to thank the organizers for inviting me as a moderator for this session. And we'll start the session with, and there's a first session of the Sarcoidosis Summit, Rheumatology Session, and the first speaker is none other than Dr. Pradeep Bhambre, because I think he has most experience in sarcoidosis, to my knowledge. In a brief introduction about Dr. Pradeep Bhambre, currently practicing in White Bay Private Day Hospital, Queensland, Australia, was associated with the University of Queensland, Clinical Director of Medicine, Queensland, physician from PGIMER, Chandigarh, and he has more than 80 publications. Dr. Pradeep Bhambre, over to you, sir.
Hello?
Yes, we can hear you, sir.
Okay, all right, that's good. First of all, thank you very much for inviting me, and I like Dr. Reddy's statement about it involving the whole body, and people don't want to think about it. So in order to, just one sec. Yes. One sec. All right, one sec. How do you, okay, 1 minute. I need to go back. One sec. Just hang on a sec. And show, let me go back, share screen. Yes, I clicked on that. Is that sharing now? Slideshow from beginning. Is that all right? Okay, all right. Thank you, Dr. Varaprasad, for your very kind words. Dr. Reddy set the theme very well in saying it's a multi-system problem. Unfortunately, not too many people are willing to delve into it. I was very fortunate at the PGI to have a team of people who were involved and helpful. So I will talk to you about sarcoidosis as a rheumatologist. And we'll start with the first illustration. As you can see, this is Mrs. Mortimer with the skin lesions who excited the interest of Jonathan Hutchinson. This picture was given to me by Jerry James, and I'll talk to you about him. All right. Why does it not move? Slides not moving. Yep, the slide's not moving.
Just click on the slide, sir. It will work.
Okay.
Share it again, sir.
All right. I've done the share screen. I've got. Okay.
No, we are not getting.
You're getting?
No, sir. No.
No?
Please share the presentation again, sir. The same way.
Okay,
you did before.
one sec. I'll just go back. I'll get out of this and show, minimize, go back to this, share screen. Uh,
Yes, sir. You can go to the presentation.
All right, one sec. Slideshow from beginning.
Sir, just press from beginning, sir. From beginning.
Can you go to the next slide, sir? We'll just run like this.
Second moderator, Dr. Raj Kiran, has just joined the session. So can you please introduce Dr. Aman Sharma? We are moving on to the second topic.
Hello? Zoom has quit.
On screen. Good afternoon, everyone. Our next speaker is a very quite famous personality in rheumatology, in the field of rheumatology. He is a hardcore researcher, day in and day out. Like he is into the field of rheumatology since last 15 years. We have been listening to him, and he did lots of work in vasculitis, and he is the founder of Indian Vasculitis Database. And he, apart from his research work, he is also an executive member and served as executive member for Indian Rheumatology Association for quite a long years, and now currently is secretary of Indian Rheumatology Association. He is our inspiration into rheumatology and vasculitis research. He is Professor Aman Sharma. Currently, he is professor of and HOD of clinical immunology and rheumatology
If I email the slides to you.
in PGI Chandigarh. Dr. Aman?
The presentation. All right, let me just see if I can do that. Okay, I'll try that in a minute. Yeah. Yeah, I've got your email, isn't it? It's that. Okay. Sarcoidosis Summit. Okay, all right. Okay, all right. Okay.
Hello, everyone. At the outset, I would like to thank Dr. Jugal Kishore for this very kind invitation to present atypical presentations of sarcoidosis/overlap syndrome, and also giving me an opportunity to share the platform besides my mentor, Professor Pradeep Bambri, who was someone who sensitized the Indian rheumatology fraternity regarding the existence of sarcoidosis. Prior to that, many people believed that this entity doesn't really exist in this country. So if we look at the different organ involvement, this is the access study data, and it shows I've highlighted the presentations which were sent as far as organ system involvement is concerned. As you can see, these various organ systems involvements are less than 5%. And in the next 14 or 15 minutes or so, I will share our experience of some atypical cases. I'll begin with the first case. This was a lady who was referred to us in 2017 from Mangalore. She in 2002, she had low-grade fever, cervical enteropathy, and there was FNA evidence of granulomatous inflammation, and it was negative. A trial of ATT was given with some improvement, but she never felt really absolutely all right even after receiving the ATT, and some symptoms persisted. In 2005, these symptoms again increased, and she had started her low-grade fever. She was detected to have cervical and axillary lymphadenopathy, and also there was a patch of consolidation. And that is when a biopsy which had been done showed there were granulomas, there were compact granulomas, and as you can see here, and there were even granulomas within a granuloma at various sites, and there were these asteroid bodies also seen. So this time a possibility of sarcoidosis was considered, and she was started on steroids and azathioprine in 2005, which was continued till 2009. Then after almost year and a half or so, she started to have epistaxis, nasal crusting. Gradually, she developed a defect on the ala nasi on the left side, which progressively increased over a period of time. And there were multiple biopsies also done at different time intervals, which I will share when I discuss about the histopathology finding. And when she developed a very gory, very bad kind of a hole on the left side, she was referred to us. These are the pictures that I've shown you. This started with a normal bridge of the nose with some defect on the left side, which progressively increased over a period of time to an extent that she became so miserable that she had even suicidal thoughts because she thought that she can't show her face to anyone. ANCAs had been done, both IF and PR3, and all were negative. The radiology also did show the same changes as we had seen on the clinical examination. There was progressively increasing involvement of the sinus areas. In 2000 here, it started off with some mucosal thickening, some and some sinus involvement, which had increased. There was some mucosal thickening again in 2011 with nasal deviation. By this time, we can see that there is even radiological evidence of the defect in the ala nasi, and there was beginning of this increase in the sinus disease on one side, the maxillary sinuses in 2014, and there was involvement on the other side also. There are other maxillary sinuses which are involved, and there is a destruction of the lateral wall of the sinus, which the defect had increased. You can see the septal defect here, the sinus involvement on both the sides in 2016. As you can see here, the so much mucosal thickening, ethmoid, maxillary sinuses involved. As I told, various biopsies had been done. The first biopsy was a left nasal biopsy done in 2011, which showed extensive areas of hemorrhages and necrosis. There was no granuloma or giant cells. That did entertain a possibility of Wegener's or a possibility of midline granuloma. Two biopsies were done in 2016, one in October and the next one in December. And the one that we could lay our hands on, area of ulceration or necrosis. These are the old reports, a neutrophil infiltration or a granuloma. And the other one was nasal septal ulceration and epithelioid granulomas, and nasal mucosa showing chronic inflammatory cells with scattered neutrophils. Was it a sinonasal sarcoidosis, or it was a sarcoidosis with systemic vasculitis, necrotizing sarcoid granulomatosis, or it was a new onset systemic vasculitis like limited GP. I requested our Professor Ritambra Nada, our histopathology colleague, and she was kind enough to review the slides the same day, and the slide did show different ages of vasculitis in different biopsy specimens, which was beautifully highlighted in one of these EVG stains. Now the dilemma was whether sarcoidosis everywhere, or it is sarcoid with necrotizing, is it sarcoid necrotizing sarcoid granulomatosis. Professor Ritambra Nada at that time was visiting the US, and she did discuss these slides with Professor Charles Jennett, with whom she had spent some time in Chapel Hill, North Carolina, and he also agreed that these are two different entities. This lady had sarcoidosis to begin with, and subsequently she has features of Wegener's granulomatosis. So if we look at the necrotizing sinonasal disease, both GPA and sarcoidosis are amongst the differentials of necrotizing sinonasal disease. And if you look at the diagnostic criteria of sinonasal sarcoidosis, besides the radiological evidence of sinusitis, there has to be granuloma and histopathology, and there should be no evidence of vasculitis, unlike what we saw in our patient. And if you look at the sinus involvements, there are various types like atrophic, hypertrophic, destructive, and nasal enlargement. And if you look at the destructive involvement of sinonasal involvement of sarcoidosis, the differentials again are Wegener's granulomatosis, NK cell lymphoma, and cocaine abuse. These two were not there in our patient, and probably this is what we were, GPA was what we were dealing with. When we tease out the literature further, it said that to differentiate between NSG and GPA, unlike those with GPA, patients with NSG have no upper airway disease, glomerulonephritis, or systemic vasculitis. So perhaps this lady had both these problems. Another challenging case that we saw with our ophthalmology colleagues was a middle-aged lady with 80 years of diabetes and hypertension. She had a painful progressive vision loss of 20 days, which was even prior to one record of high blood pressures of 250 and 120. And seen by Professor Amod Gupta in the Uveitis clinic. She had visual acuity of 6/60, but there were cells in the anterior chamber, and they were posterior cyanoicky, suggesting there was some anterior inflammation, anterior uveitis going on for some time. And this is the disc picture. You can see there are hemorrhages, there is a disc edema, and there are also what we later identified on review are these what we call as sarcoid granulomas. There was atypical chest pain, which was non-anginal, non-pleuritic. There was some dyspnea and dry cough for 1 month. These are two ECGs. The upper one and the lower ones are the ones done at 6 hours interval. As you can see, there is some ST segment depression here, more marked in L2, which became all right. Their T waves have become upright here after 6 hours. Similar changes were observed in the lateral chest leads V4, V5, V6, which again also normalized. The T wave you can see have become upright. So in the lateral leads, there was initially ST segment depression, which normalized. There was mediastinal, hilar and paratracheal lymphadenopathy, and their HRCT classical or sarcoidosis. This lady did undergo a biopsy which showed non-caseating epithelioid cell granulomas. and she was started on steroids. Initial with that blood pressure reading, there was an initial possibility of it being a malignant hypertension, but the cells in the interior chamber, Synechi, and the chest radiology findings made us believe that this could all be sarcoidosis, even though the patient had uncontrolled sugars and high blood pressure, had to be treated with steroids and with complete restoration vision. And there you can see the disc edema had disappeared, the hemorrhages had disappeared, but there was some mild optic atrophy which had set in. So the optic nerve involvement in sarcoidosis is rare. Papilledema can be due to increased CSF pressure. There can be anterior and posterior neuropathy, disc elevation due to infiltration, optic nerve head mass, and optic atrophy in the late course. Another patient, which probably is more for relevance of the rheumatologist, of young male referred as Sjogren syndrome from IGMC Shimla because of history of dry eyes, Schirmer 1 and 4 mm and bilateral parotid swelling. Anti-Ro, anti-La and ANA were negative. Salivary gland scintigraphy did show preserved trapping function in bilateral parotids with an impaired drainage. A lip biopsy had already been done, which was inconclusive. So we saw the patient, but we also looked at the X-ray, wherein we saw there is hilar prominence, there is suggestion of mediastinal retinopathy, which was confirmed on the CT scan, and there was enough evidence of interstitial lung disease on the CT, as you can see, and the patient was subjected to transbronchial biopsy, which did show interstitial granulomas. This image is of courtesy Professor Amanjit from histopathology, and non-caseating compact granulomas, confirming our diagnosis of sarcoidosis. And he was started on corticosteroids and hydroxychloroquine and did well. And we now have almost 10 years of follow-up, and the patient is doing fine and is absolutely asymptomatic, unlike what would have happened with Sjogren syndrome. Although there are some case reports of Sjogren's overlap with sarcoid, but the fact that patient is absolutely asymptomatic 11 years down the line, that possibility cannot be entertained in this patient. Another patient, a lady who only had a skin problem and some vomitings, skin problem starting off with plaque-like lesions which progressively include different areas, and eventually was admitted with vomit. She had these rounded plaque-like lesions which had indurated margins and scaling. To a lay person, it might look like probably psoriasis. One might just pass this off as psoriasis. Face, arms, as you can see here, but a biopsy had been done which had shown a granulomatous inflammation. So we looked for sarcoidosis along with our dermatology colleagues. The slit rect examination did show band-shaped keratopathy, and there was evidence of some dye leak, and there were some microaneurysms seen. As you can see, there is a leak of the dye and microaneurysm. We're going to have a talk on ocular involvement in sarcoidosis. There was renal dysfunction, and there was high ESR, and urinary calcium was also elevated. It was 14 to begin with, and with steroid it had come down to 12. This patient was admitted with us recently, is still on in the wards, and the urinary proteins were 320 grams. Did have some ECG changes like our previous patient. There was some cardiac enzyme elevation and low ejection fraction with global anesthesia. You can see the CT evidence of mild central bronchiectasis with peribronchial thickening, which is more marked in the right middle lobe, and there was a periphyseal, peribronchovascular and subpleural nodules which are seen here. And this is the biopsy report which I am sharing with you. It did show both the skin biopsy from the scalp and the back showed granulomatous inflammation favoring sarcoidosis. So ladies and gentlemen, you can see the problem was only in the skin for the patient, but it was widespread, involving various organs, involving the eyes and also the lungs. So I think we have to keep our suspicion, index of suspicion, very low. To conclude, I'm sharing a case shared by Professor S.K. Sinha from gastroenterology. A patient with cholestatic jaundice for 4 weeks with hyperbilirubinemia, increased transaminases, viral markers, autoimmune hepatitis workup and TTG valor negative, serum ceruloplasmin is normal. There was no response to therapy for 12 weeks, and patient continued to have intense pruritus, deep jaundice, although there was no liver failure. ERCP was normal. There was no evidence of primary sclerosing cholangitis, and necessitating external biliary drainage for 4 days. After 2 weeks of external biliary drainage, there was symptomatic improvement. There was no pruritus because the system had been drained. There was some hyperbilirubinemia still persisting, although liver enzymes had come down, but they were still almost 2 to 3 times. NBD was removed as after 2 weeks as the patient had become asymptomatic, but continued to have fatigue and now had mild dry cough and shortness of breath. And the alkaline phosphatase had now elevated to around 3 times the upper limit of normal. When a liver biopsy was done, which showed granulomatous inflammation, ACE levels were elevated, MAN2 is negative, 24-hour urinary calcium was also elevated, and CT at this time did show mediastinal adenopathy and interstitial lung disease. That confirmed because at that time most lesions were FDG avid. Patient was treated with steroids with resulting in decrease in the ACE levels, PET normalization of FDG lesions, LFT is becoming normal, and steroid taper off over the next 6 months and then stopped. So this was a liver involvement due to sarcoidosis. So ladies and gentlemen, I'll wish to conclude by saying that sarcoidosis can present with diverse and atypical manifestations, and multispecialty care is the key to good outcome. Thank you very much for your patient hearing, and I'll be very happy to take any questions. Thank you, Dr. Jugal, once again.
Professor Aman, are you there?
Yeah, I'm here.
Thank you for that wonderful lecture. So you have touched upon almost lots of overlaps and also like lots of specialities in your talk. Thank you for this wonderful talk, and we'll take questions after the next session, after the next talk, sorry, from Professor Vikas Agarwal. After that, we'll club and we'll have a question and answer session after these 3 talks. So we'll now move to our next talk. It's from Professor Vikas Agarwal. Professor Vikas Agarwal is professor in Department of Clinical Immunology and Rheumatology at SGPGI Lucknow. He has more than 500 publications in various journals, and Professor Vikas is currently editor-in-chief of Indian Journal of Rheumatology. Over to you, Professor Vikas.
Everyone, today I'll be discussing current concepts in immunosuppression and challenges in Indian scenario. I have no disclosures to make. Immunosuppression is a state of reduced activation of immune system whereby it doesn't respond to an antigen to which normally does. It could be because of underlying disease, drugs used to treat that particular disease, and certain complications like infection or malignancy. Since meeting is restricted to sarcoidosis, so I will also restrict my discussion to sarcoidosis. Management of sarcoid is challenging because of the diverse clinical manifestations, and the guiding principles remains the same. If there is any risk of organ failure or death, then these patients need treatment. If there is an impaired quality of life due to disease, then these patients need treatment. The goal of therapy is to minimize or suppress inflammation-induced organ dysfunction. Since sarcoidosis is predominantly a pulmonary disease, so if there is any bothersome pulmonary symptoms or any deteriorating lung functions based on pulmonary function tests, or if there is any progressive radiographic deterioration, then these patients need to be treated with immunosuppressive agents. Patients with extrapulmonary sarcoidosis, besides the skin involvement, are actually candidates for treatment of immunosuppressive agents. Glucocorticoids form the cornerstone of treatment because they are being used as first-line agent. Methotrexate, azathioprine, leflunomide, and mycophenolate are second-line agents, and biologics, including anti-TNF as well as anti-GCSF therapy and cyclophosphamide, are considered to be used as third-line agents. All these agents carry a substantial risk of toxicities, including myelosuppression, hepatotoxicity, GI toxicity, as well as infections. There are concerns with the use of glucocorticoids, since it is widely used in sarcoidosis. A whole plethora of serious side effects have been reported, right from hormonal disturbances to metabolic syndromes and risk of infections. So it is considered that patients should be selected very carefully. And the dose of glucocorticoid to be initiated and then subsequently should be adjusted so that you minimize these adverse effects. And if there is any need to give any kind of prophylaxis, be it for infection or osteoporosis or others, one need to take into that consideration while treating with glucocorticoids. Even a slight jump in the dose of glucocorticoids from 5 to 10 to 10 to 15 actually makes a quantum jump in glucocorticoid-induced side effects, as has been reported in this earlier study. With long-term use of glucocorticoid, the cumulative dose of steroid increases the risk of infections, including fungal, viral, bacterial, and also mycobacterial infections. This study from UK actually reported that even anytime exposure to glucocorticoid increases risk of getting mycobacterial infections. So one has to be very careful in evaluating patients before initiating them on glucocorticoids. Not only glucocorticoids, but immunosuppressive agents, second line, they also increase, as well as third line, they also increase the risk of infections, as has been reported in this particular study from pregnant females who were actually having autoimmune inflammatory conditions and were receiving glucocorticoids and immunosuppressive agents. But the risk was highest with glucocorticoids, and this risk increases with the dose of glucocorticoid, as has been demonstrated in the graph shown below. In sarcoidosis, severe infections have been reported from a Swedish cohort, and this is an observational study. It was reported that patients of sarcoidosis have got serious infection from bacterial, viral, fungal, parasitic, as well as mycobacterial infections. And two particular things come out of this study: that patients who are on 3 or more immunosuppressants are receiving cyclophosphamide, as well as extra pulmonary sarcoid patients like neurosarcoid or cardiac sarcoid are actually likely to have severe infections. So one need to pay attention to these patients when you are treating sarcoidosis. Taking data from hemato-oncology units as well as organ transplant unit, it was realized that pneumocystis xerovicii infection are very common, and these patients need to be treated with some kind of a prophylaxis when initiating them on glucocorticoids, especially those who receive glucocorticoid at a dose more than 20 milligram per day, or who are receiving biologics. Besides infections, other usual side effects of glucocorticoid in form of osteoporosis, ulcer, gastroesophageal ulcer, cardiovascular health, diabetes, and eye problems need to be taken care of by adequate history examination and prophylaxis. Just one word about glucocorticoid-induced osteoporosis. Sarcoidosis. It is challenging because sarcoid granulomas do secrete a lot of vitamin D. So there is always a risk of hypercalcemia and induced complications if you give too much of excessive vitamin D and calcium to these patients. So these patients need to be closely monitored for this. And also one should not wait for BMDs to decrease before initiating some kind of prophylaxis, because the fracture risk increases without any significant decrease in bone densitometry in these patients. The other concern which one has to take into consideration while treating patients on long-term immunosuppression is the risk of malignancy. And malignancies have been reported to be increased in patients with sarcoidosis. And this report, as early as 1974, actually showed increased risk of lung as well as lymphomas in patients with sarcoidosis. Patients who receive immunosuppression are actually having much more increased risk of malignancy risk, as has been reported. This study from Scandinavia, and all kind of malignancies have been reported here. One has to keep in mind that there is a 40% overall increase in incidence of cancer in patients with sarcoidosis. So one need to always keep that in back of mind and keep looking for any earliest sign of malignancy. So when to suspect cancer in patients with sarcoidosis? If these patients are getting hospitalized, they are more likely to have risk of cancer. or there are atypical manifestations like involvement of peritoneum, gut, any new organ involvement despite treatment, and patients tend to have refractory disease. These patients need to be carefully monitored for underlying. Methotrexate has been used in patients sarcoid as a second line agent, and this is the most frequent immunosuppressive agent or disease modifying drug which is being used. It has got its own toxicity in form of GI and the hepatotoxicity and also cytopenias. So one just need to evaluate patients at baseline and carefully screen them for absolute and relative contraindications. And the dose adjustment should be such that patients should receive the lowest effective dose of methotrexate, and periodic monitoring of side effects should be done. Generally, in our immunology rheumatology clinics, we start with a low dose and then gradually escalate methotrexate depending on the response to treatment and the tolerance of the patient. One need to be carefully considering patients who are malnourished, diabetic, obese, who take alcohol, or who had got underlying disease of liver. Then these patients need to be carefully monitored for methotrexate-induced toxicities. It has been reported from Scandinavia that patients of sarcoidosis receiving methotrexate and or azathioprine are likely to have greater toxicity, especially azathioprine patients tend to have more infections as compared to methotrexate. So these are well-known immunosuppressive agents which have got toxicities in the other organ system also. Again, baseline screening for potential toxicities as well as high risk of index of suspicion of infection and malignancies at each and every visit can actually obviate complications in form of serious infection or malignancy in patients of sarcoidosis receiving these agents. Infliximab is the most common biologic used in patients with sarcoidosis. And the two most common side effects which we are actually dreading is the infection and the malignancies. So one has to screen the patient for use of infliximab at baseline very carefully. So these patients need to be on history and examination evaluated for possible underlying infection and malignancy and screened for tuberculosis, latent tuberculosis. The principle of uses of biologic is that the lowest effective dose should be used, preferably as monotherapy. And if they are combined with other disease-modifying drugs, then one has to very carefully monitor for potential toxicities at each and every visit. Since infection remains the major concern, and this is much more relevant to our country, one needs to vaccinate patients, which we generally don't do before initiating them on any kind of immunosuppressive. One can either follow society guidelines or local guidelines for usage of vaccinations. Only one thing needs to be considered when you are using vaccines, that live attenuated vaccines are absolute contraindicated in patients who are receiving immunosuppressive agents with steroid, disease-modifying drugs as well as vaccines. So in Indian scenario, few peculiar challenges are there, that most of our patients are poor and uneducated, so they need to be educated regarding the disease and the drug, including the side effects profile at baseline and also at each and every visit. They should be educated about symptoms and signs of malignancy as well as infections, and in case they should be asked to go back immediately. Since India is a country where complementary alternative medicines are very commonly used, so patients should be told that one should not mix complementary alternative medicine with the current medical regime which they are receiving, because they are more likely to cause toxicities. And besides, the general hygiene, food hygiene, oral hygiene needs to be told to these patients. For physicians, screening patient for infection or malignancy prior to initiating immunosuppression. Physician should take care of vaccinations before initiating immunosuppression. And if patient is actually being used or is on glucocorticoid, then it should be used judiciously with the early tapering to the maintenance dose. And physician should actually bring on steroid sparing agents early on in the disease course. And patients who receive second or third line agents should only receive when they are appropriately indicated. Patients should be monitored for infections and malignancy and other side effects at each and every visit. So till we have better drugs available to control inflammation or for the disease of sarcoidosis, one should remember that immunosuppression is a balancing act on a tightrope. However, if you are careful and if you play your cards right, then you can successfully reach at the end of the road. With this, I would like to end my presentation and will welcome any comments, suggestions, or questions. Thank you.
Thank you, sir, Vikas sir, for the excellent lecture, covering extensively all the basics and the important points. Now we can have some questions from the floor, please, sir.
I am Dr. P.N. Rao. I'm a hepatologist. And the question is that, is sarcoidosis basically an immunosuppressed condition? Because whatever infections have been detected are mostly in patients who have been treated with immunosuppressive drugs. And basically, sarcoidosis in any organ ultimately ends in the end organ damage. Do we have any evidence to show that any of the parallel studies or controlled studies that sarcoidosis itself is associated with any immune related infections?
Is this question for me?
Yes, Professor Aman. Is sarcoidosis a disease by itself is an immunosuppressive state? I think that's the question.
So for me or for Vikas sir? Okay. Sir has tried to answer first, so maybe first he can take up and then I'll answer. Vikas sir, you wanted to say something?
So if you see the literature, there are innumerable number of reports where people have looked at different kinds of infections as the underlying etiology for sarcoidosis. It varies from an abnormal immune response to mycobacterium to various viruses and different pathogens as well. If you are really ask me whether sarcoidosis per se is an immunosuppressive state, I will say yes, it is an immunosuppressive state because the immune system is inappropriately active. At sites where the disease is progressing, it is a type Th1 type of a response or Th17 kind of a response. Whereas at other sites, there is actually sort of a response which is more like Th2, or there is immunosuppressive state, and the T cells at that site do not mount any kind of an immune response. So it is a paradox that at sites in the very same patient, in the very same disease, there are sites or organs where the disease is active and is pro-inflammatory, and at other sites it is actually behaving like a more of a anti-inflammatory driven immune response. Aman, will you like to add something?
Yeah. So, and just in continuation of what you have said, I will also concur with you in the sense that it's right that it is an immunosuppressed state and the people is meant to becoming negative. So it is said that somebody who's had pulmonary tuberculosis in the past, am I audible? So
yes, very much.
In the past, and my seniors have, have shown some patients of pulmonary tuberculosis who had documented MANTU positivity in the beginning, some years ago, then developed the manifestations of sarcoidosis later on, which is necessitating immunosuppressive therapy. At that point in time, the MANTU had become negative. So we all know that there is energy and the MANTU is negative, akin to what happens in various immunosuppressive conditions. This is also kind of a clinical surrogate marker of what akin to what Dr. Vikas tried to explain immunologically. And we are all aware that obviously there is immune alteration also in the form of various granuloma formations, which you don't really expect generally broadly in advanced immunosuppressive states, and that necessitates response to immunosuppressive therapy. So kind of the answer to both your comments is yes, and you give them both. And your take on infections, jury is still out. People have, the closer that people have talked about is initially people have done PCRs from the sarcoid tissues and shown that there were PCR positivity for some of the sequences which were there with Mycobacterium tuberculosis, and people thought that is it due to some kind of a response to mycobacterial infection. But that fact is not clinically held true in the sense that many of these patients are treated with high doses of steroids for a long period of time, but never develop active disseminated pulmonary tuberculosis, which would happen in a patient with on corticosteroid. Rather, I remember Professor Watson was here many years ago, and he did throw up the idea of NTMs rather than Mycobacterium tuberculosis playing an orchestrating role. But I don't think, jury is still out. I don't think we have an answer whether it is a response to an element or an environmental factor or virus. But for sure, we don't have any evidence, proven conclusive evidence of any infection driving as of now. And the fact that these are on immunosuppression and not much, same type of infection documented because of immunosuppression, something which we need to ponder.
Both the speakers agree that sarcoidosis itself is an immunosuppressed state, and the treatment also can sometimes put the patient at risk. Dr. Pradeep Brambre, who couldn't give the first lecture, he has joined the session again. So, Dr. Pradeep Brambre lecture on the importance of sarcoidosis, a rheumatologist perspective. Do we have Pradeep Brambre online? Before Dr. Bombay, Pradeep sir joins, can I ask a question about the role of latex?
The audio, can you hear me?
Yeah, okay.
Yeah. Okay. Okay, show me the slides. Hello? Can you show the slides? Please.
1 second, sir. 1 second.
Okay.
You can see them, sir.
Yes, I can.
Go ahead, sir, and just say next slide. I'll keep.
All right. We might as well go to the next slide. You've had a detailed discussion on lots of things. This is how the story all started. This is Mrs. Morton. You can see it's the skin that was the important thing. Next slide, please. In the 19th century, sarcoid was a dermatological curiosity, but the multi-system nature of the beast was apparent in the early 1900s, and by 1930, it was fully established as a multi-system. Next slide, please. So how does it affect a rheumatologist? In a pediatric age group under the age of 4, in populations that are predominantly Caucasian, children may present with a red maculopapular rash, uveitis, and arthritis with very limited or no lung damage. This, next slide please, this undoubtedly makes it a differential diagnosis of juvenile idiopathic arthritis or inflammatory arthritis. And one needs to be cognizant of this fact when one is dealing with small children. Next slide please. In an older child, it mimics adult multi-system disease, and therefore no special considerations are required. Next slide, please. In adult rheumatology, sarcoidosis can produce arthritis, which can be acute or chronic. involve the bones or the muscles. Next slide, please. The acute sarcoid arthritis goes by this epithet of Lofgren syndrome described in Sweden of arthritis, uveitis, erythema nodosum, and hilar lymphadenopathy. This is a classic group of symptoms associated with a good clinical outcome. Next slide, please. And this is one of my patients. You can see the ankle arthritis, not that good. The erythema nodosum is a lot better seen. The uveitis and the hilar lymphadenopathy. Next, please. In the Caucasian population, acute sarcoid arthritis involves women more than men, is associated with fever, constitutional symptoms, involves the ankles, knees, and ankles more than the knees, more than the wrists, unlike rheumatoid arthritis. And it's usually symmetrical, so it's a differential diagnosis. Next slide, please. And these are two examples of ankle arthritis. They are not in a Caucasian population, but they are the types of lesions one might see. Next slide, please. Chronic sarcoid arthritis, on the other hand, is very much a feature of the African races. Again, women dominate with a symmetrical, deforming, relapsing arthritis. And it can be extremely debilitating. Next slide, please. As you can see in these pictures, which are not my patients, but I got them from the net, it's a mutilating form of arthritis. And looking at the nails, one would think that this is psoriatic arthritis, but this is actually biopsy-proven sarcoid. Next, please. This condition is associated with a poor response to treatment, and it's associated with chronic skin, eye, CNS, and fibrotic lung disease. Next slide, please. As you can see, this is another set of hands with findings which look just like sausage digits, dactylitis, nail involvement, cavitary. There's an eye which is not seeing too much because of recurrent uveitis, a stuck pupil, and possible glaucoma. And there's skin infiltration at the philtrum, which is quite typical of a start of lupus pernio. Next, please. Bone sarcoid produces cystic and lytic lesions. So this is the clinical photograph of a cystic lesion in a patient's thumb. These are X-rays which show cystic lesions at multiple locations in the hands and feet. There may or may not be a periosteal reaction. Next, please. Lupus pernio is common in these patients. This is a slide given to me by Dr. Jerry James, and I'll show you a picture of him at the end. But this is a very typical lesion, involves the tip of the nose, and is a very disfiguring condition. Next, please. Muscle sarcoid resembles polymyositis and is steroid responsive. Next. Next slide. Whereas chronic muscle sarcoidosis affects elderly women, it's symmetric, proximal, with wasting, poor response to steroids. There is a nodular form which shows tender subcutaneous nodules. I've never seen one, but that's recorded in literature. Next, please. I did see about 250 patients at the PGI when I was there, and males dominated. Next, please. In this entire group of patients, there were about 40% had joint pains. Skin and eye involvement was very frequent, and that is because I had a skewed collection of patients because of my associations with dermatology and ophthalmology. Next, please. Sarcoid arthritis. Next, please. And in 90% of them, it was acute. In than 10% it was a chronic arthropathy. So 3 patients with bone sarcoid and 1 with muscle. Next, please. The question that this audience needs to look at is that as a general rheumatologist, when does one think that a patient might have sarcoidosis? Next slide, please. Next, please. So if there is a clear-cut Lofgren syndrome, you have the diagnosis in your hands. The next, please. There is another named syndrome after Jan Waldenstrom, the uveo-parotid syndrome. If you have that in association with arthritis, you have a diagnosis. But there are several times when these things are not so clear-cut. Next slide, please. So if the arthritis is confined to the ankle and there is no evidence of gout, that's when I would like to think about sarcoidosis. Next, please. I'd like to think about a patient with joint disease who has relapsing acute anterior uveitis. Next, please. Or patients with various kinds of skin lesions. And I'll show you some pictures. Next slide, please. So they can take all sorts of forms. Now, this is a lupus pernio, the top corner here. It's a gentleman with thickening of the ala of the nose. This is a chronic infiltrative disorder. You can see that there are plaques, which is seen on the dorsum of the hand and on the back, which look just like psoriasis. There's infiltration of the ear. There are chronic scarring, pitting scars along the back. And in this person, he had ill-fitting spectacles and he had a scar there that got inflamed and angry, producing scar sarcoidosis. Next, please. I'll take a break here. You can see this is a painting on the Louvre. It's painted by Domenico Ghirlandaio, which shows an old man with multiple skin lesions. Shows that it's compatible with relatively longer survival. The important thing about this man was that he was a teacher of art, and one of his students happened to be Michelangelo. Next, please. He taught him how to paint fresco. Now, an enlarged version of this picture will show you these kinds of lesions, and one of my patients, 500 years later, had a similar lesion on their scalp. Next slide, please. So this is a sarcoid granuloma. Next slide, please. About 80 years ago, Winston Churchill described the Soviet Union as a riddle wrapped in a mystery inside an enigma. Unfortunately, today it remains pretty much the same. Next slide, please. But what does this have to do with sarcoid? Next slide, please. So the riddle is, just go back one slide. The riddle is, what is the exciting antigen at the center of the granuloma? The mystery is the behavior of the immune system around it. And the enigma is the fibrosis that affects some people and not others. Next slide, please. In the skin, sarcoid moves from erythema nodosum to papular and nodular, and then plaque lesions and lupus pernio in terms of chronicity. Next slide, please. When arthritis is added to the mix, you have acute arthritis, you have chronic arthritis, and bone cysts in the same sequence. Next, please. Illnesses at this side of the spectrum here are short duration and responsive to steroids. Those at this end are chronic, relapsing, and relatively unresponsive and require other agents. So you've already heard Vikas, and I'm going to talk about the various ramifications of all of this. Next slide, please. I just want to acknowledge the help that Dr. Jerian James gave me. He's seen here with his more famous wife, Dame Sheila Sherlock. Next slide, please. And this is a picture from my backyard. This is a real bird with real flowers. And that's just a great thank you to you for putting up with me and for putting up with the nuisance I created. Thank you very much.
Thank you, sir, for an excellent lecture. We have two questions. All the panelists, everyone is available, I think. How to differentiate chronic sarcoid myopathy with present with proximal myopathy versus steroid myopathy, especially if a patient is already on treatment with steroids?
Well, you've got to do a biopsy and you get the granulomas, you'll know.
Thank you, sir. And the second question, how important is it to screen for malignancy in sarcoidosis? Dr. Vikas sir's talk mentioned about malignancy, risk of malignancies.
Oh yeah, there is an increased risk of malignancy. There is extra stuff that came out of the Danish Cancer Register, and they linked, because they have registry of all things, and this was in the early 1980s before the computer programs were that good, and they linked lymphoma and sarcoid. So it's important to remain cognizant of the fact that the system, that things may change. So if you have someone who is doing relatively well and starts to deteriorate, that's when you start thinking, what are we dealing with? Have we got something else going on here? So that's what I would do. I don't see much sarcoid here in Australia, but that's what I would do if I was still doing what I used to do.
Okay, thank you, sir. Do you have any other questions from the floor? Sir, sorry, sir.
Okay.
One more question.
Yep.
It's not a question, just a thought. My name is Sharat Chandra Mode. I'm a rheumatologist working in one of the corporates. Why we see TB more in the Asian people and sarcoid in Caucasians?
That's not exactly true. Actually, there are very detailed analyses available from the prevalence of sarcoidosis in London versus tuberculosis. And there is a clear crossover point just after the Second World War where the prevalence of tuberculosis started to decline, the prevalence of sarcoidosis started to go up. And there is a clear cross in that. The belief, that's where the belief came from, that it is an altered response to something from the mycobacterium. And as Aman said, they've looked at lots and lots of things, lots of germs, lots of pollens, lots of dusts. Even the dust that came out of the World Trade Center has been attributed to have sarcoidogenic properties. So with tuberculosis, I don't think the final answer is available. It's a very it's a very tempting link, and we have all seen patients who have had tuberculosis, had treatment, then developed sarcoidosis, and vice versa.
So definitely, so when I was working in England, I saw we used to organize sarcoid clinics. Definitely, the prevalence of TB is much less, and sarcoid is more in Caucasians. That's my practical experience. Then the other hypothesis what I have is it the same, spectrum at the different ends? One end is COX, the other end is sarcoid. It is the host response to the old tubercular pathogen, dead pathogen, because the research paper says that I think up to 1/3 of the people, the biopsy identified the DNA, tubercular DNA in the biopsy. So is the host response to the pathogen. At the one end it is the TB, the other end is the sarcoid. Just your thoughts.
Well, this has been debated for a very long time. It's not a new hypothesis. It's a hypothesis that is probably about 70 or 80 years old, that there is a link between the two. Definitely there is enough grounds to suspect a link. But what is that link? The fact that 80 years later or 70 years later, we're still pondering about what is that link, we don't know. And I guess maybe if we are still around 20 years from now, somebody will have found the reason why this response can switch. It goes from one form of response producing tubercular disease to another form of response producing sarcoidosis with tubercular energy to tuberculin, which is a change or switch in the immune system. And that's something that the exact details have to emerge. I can't offer an explanation for it.
So I have a question. As a rheumatologist, we see a different kind of sarcoid, but here in AIG, they have lots of series of cardiac sarcoid. Dr. Narasimhan is the boss. I think has got the world's biggest number of cardiac sarcoids. Do you think the cardiac sarcoid is a different phenotype, different from other sarcoids? What do we see as rheumatologists?
I can't answer that question because I don't know.
Because in our Dr. Narasimhan, in our clinics, for our sarcoid patients, we don't see, hardly we see. Probably I have a couple of cases of cardiac sarcoid. Rest of them, they manifest with the lung and MSK manifestation.
Thank you very much for bringing this up.
If you are an ophthalmologist, you'll see only ophthalmic sarcoid. If you are a dermatologist, you'll see only dermal sarcoid. If you are a neurologist, you'll see neurosarcoid. It depends on what your specialty is and your inclination of trying to find an answer to a problem.
It's exactly, there is a selection bias depending on the specialty we practice. We tend to see more of isolated sarcoid because patients with unexplained VT, unexplained AV blocks, unexplained heart failure, we start investigating. One of the thing is we have realized a spectrum of patients who have been labeled as coronary artery disease, where there's mild coronary disease, they undergo interventions, but the underlying heart failure doesn't improve, and then they come back for further evaluation. By biopsy, there's a non-caseating granuloma. So there are various shades of gray, and we find that depending on the specialty you practice, we tend to get these patients to our clinics.
Thank you for not saying 50 shades.
May I? No, sir. Actually, I say, as a rheumatologist, we see the full spectrum of sarcoid, but definitely cardiac sarcoid is less. A question to Dr. Aman. As a rheumatologist, Professor Aman.
I got your point, Dr. Sarath. The question is, it basically boils down to what kind of a rheumatology practice you are practicing at. If you are in a clinic seeing only patients with joint disease and diagnosed connective tissue disease, perhaps at that point in time, the major manifestations are MSK or CTD, we may see less of sarcoid, or we may overlook a subtle, we know that the spectrum of cardiac involvement ranges from some ECG changes to cardiac conduction abnormalities to the myocardial involvement. I mean, the issue is if we are suspicious, and if you are looking for it, I think they are going to find more. Out of the 5 cases that I thought I'll show in 15 minutes that were allotted to me, 2 patients had ECG changes, and we have seen patients imaging evidence of cardiac sarcoidosis. Now we have, we can do the MRIs, which are very much advanced than what were done maybe 15-20 years ago. And also we have a PET scan, which also shows beautiful images of cardiac involvement. So we do see, I don't say that it is very, very cardiac involvement I treat or we treat. Our cardiology colleagues, Dr. Bahel is there. I'm sure sir would be knowing Dr. Bahel also. I talked to him regarding cardiac involvement, and he has seen patients with cardiac sarcoidosis. So as both my senior speakers told previously, trial rate depends what we are looking for. And like the dramaticity of the first patient came with visual involvement, but patient had ECG changes and a cardiac involvement, which presented with the optic disc and vision loss. The second patient who just had skin plaques, and two or three of those patients had nothing, no much cardiac symptoms, only ECG changes and imaging evidence of cardiac involvement. So it depends what is our clinical suspicion and how, to what extent we can really get the investigations done. And it has to be also the sensitization of the radiologist and the imaging person also, how sensitized he would be to pick up those subtle changes.
I'll tell you about that. Can I just butt in? When I started looking at sarcoid, and this is in the early 1980s, at that time, every single granuloma seen at histology was reported as consistent with tuberculosis. There was no mention of sarcoidosis, and it took a considerable amount of persuasion to get the pathologist to actually think that sarcoidosis could be a possibility. So in 40 years, I'm glad we've moved forward, and epithelioid cell granulomas are being considered in cardiac biopsies and everywhere. And I told you initially, and my practice was rheumatology in conjunction with dermatology and ophthalmology. So I saw lots of involvement in these areas.
Sir, I am Dr. Mateen, pulmonologist. I'm practicing pulmonology for almost more than 25 years now. And as you said, initially, we used to have less index of suspicion for sarcoidosis, but over a period of time, I realized that pulmonologists are the people who see the maximum number of sarcoid cases. And when we look into other systems, definitely we realize that other systems involvements are not so uncommon, because lung is the organ which is maximum involved, and people come to us with simple cough, dryness of mouth, breathlessness. So when we investigate, because pulmonology is a field which was for a long time restricted up to tuberculosis, but in the past 25 years, in my duration of practice, a lot of changes have come, and we are seeing sarcoidosis cases quite often. If we look into the eyes, if we ask about the symptoms, people say floaters have come. If we ask about cardiac, people do say palpitations have come. Multiple joint pains are invariably associated with majority of the patients. So what I feel is all the pulmonologists should look into other systems also when the case comes. And we do come across, even I have got done oral mucosal biopsy where granulomas were seen, parotid gland biopsy where granulomas were seen. And my only request to the faculty is, in spite of all investigations, even if we get a granuloma on biopsy, how sure, other than clinical things, histopathologically, can we differentiate between sarcoid granulomas and tuberculous or non-sarcoid granulomas?
Thank you, Dr. Mateen. I think, sorry for interrupting in between. In the interest of time, shall we move to next talks from couple of cases, couple of very interesting cases, one from Dr. Amrita and the other from Dr. Sunita. First, Dr. Amrita, can you present your case? After this session, if we have time, I think, Dr. Madhuri, is there any option where we can engage with our panelists for discussion?
Thank you, sir. Good evening, everyone. I am Dr. Amrita Gopalan, final year rheumatology resident from KIMS Secunderabad. Today, I'll be presenting an interesting case, an unusual presentation of sarcoidosis, that is the Darrier-Rossi syndrome. Our patient is a 36-year-old female an accountant by occupation hailing from Vishakhapatnam. She came to us with the complaints of swelling overlying the left knee joint and the left thumb since 5 months. Swelling in both the areas were insidious in onset and gradually increasing in size over the last 5 months. There was no associated pain or overlying skin changes. There was no history of preceding trauma, no history of similar swellings elsewhere in the body. No history of joint pains, skin rashes, mouth ulcers, no history of dryness of mouth or eyes, no parotid swelling, Raynaud's or skin tightening, no history of cough, expectoration, dyspnea and exertion, no history of constitutional symptoms like or loss of weight, loss of appetite. General physical examination was unremarkable. There was no pallor, no lymphadenopathy. Coming to the local examination, if you see the first picture on the right, so there is a firm or induration which was overlying the right knee joint. I would like to highlight that the swelling was not in the knee joint per se, it was in the subcutaneous plane. It was measuring approximately 6 into 6 centimeters. It had ill-defined margins, it was non-tender, and there was some mild overlying hyperpigmentation. There was no joint line tenderness or effusion. A similar swelling was noted on the left first digit over the proximal phalanx. Again here there was no underlying joint tenderness or swelling. Systemic examination, there was no hepatosplenomegaly. Respiratory examination was normal. Musculoskeletal examination, no joint tenderness or swelling elsewhere. Coming to her investigations, her blood counts were normal. Inflammatory markers, ESR and CRP were within normal limits. Serum creatinine was normal and LFT was normal. We did a HRUS of the affected areas, which showed subcutaneous fat stranding and ill-defined echogenicity, query paniculitis. This is an X-ray of her hand, which showed a soft tissue swelling overlying the proximal phalanx of the left thumb. There were no underlying bony changes. So with this presentation, we then proceeded with a deep biopsy of the thumb lesion, which showed multiple non-necrotizing epithelioid and Langhans cell granulomas. AFP and fungal stains were negative. Serum ACE level was elevated at 83. During the workup, that in the next 2 weeks, patient had an episode of acute left eye anterior uveitis, which was treated with local corticosteroids and mydriatics by the ophthalmologist. We then did a PET CT for this patient. So the PET CT, as expected, showed a hypermetabolic soft tissue swelling in the left thumb and the left index finger. It also picked up numerous active mediastinal, abdominal and pelvic lymph nodes and hypermetabolic foci in the chest wall muscles and the pelvic muscles. So our final diagnosis in this patient was sarcoidosis. The subcutaneous involvement is also known as a Darrier-Russy sarcoid. Involvement of the intercostal and pelvic muscles, lymph nodes and ocular involvement in the form of acute anterior uveitis. Patient has been started on oral steroids and weekly methotrexate, and she is currently doing very well. I would like move on to a short discussion on this case. So cutaneous sarcoidosis occurs in around 20% of sarcoid patients. The most common lesions are erythema nodosum, papules and plaques. The slightly lesser common lesions are lupus pernio and subcutaneous sarcoid. There are several rarer forms of cutaneous sarcoid such as psoriasiform, atrophic, annular, scar, verrucous, sarcoid nail, alopecia, etc. There are certain clinical associations with cutaneous sarcoidosis. If we see a patient with erythema nodosum, he or she is likely to have an acute and benign disease with a favorable prognosis with more than 80% resolution within 2 years. On the other hand, if we have a patient with lupus pernio, he or she is likely to have a chronic progressive systemic sarcoidosis with both severe pulmonary and extrathoracic involvement. Subcutaneous sarcoidosis is also associated with an increased incidence of systemic involvement. A short note on sarcoid myopathy. Most of the cases are subclinical. Clinical sarcoid myopathy happens in less than 2% of sarcoidosis patients. As described in the previous talk, there are 3 patterns: acute myositis, chronic myopathy, and nodular myopathy. It is interesting to note that sarcoid myopathy can affect the intercostal muscles, diaphragm, pharyngeal muscles, and extraocular muscles. Investigations show only mild to moderate CPK elevation and granulomatous changes on histopathological examination. This is a characteristic well-described sign on PET-CT known as a tiger man sign, where there is diffuse hypermetabolism noted in the affected muscles. With this, I conclude my presentation. Pose my questions to the moderators. What is the role of PET-CT in diagnosis of sarcoidosis? For example, if we have a patient with a cutaneous sarcoid or an eye involvement, should we do a PET-CT in these patients? And the second question is, we might pick up a lot of subclinical organ involvement on PET-CT as in this patient. What are your comments on hiking immunosuppression based on imaging findings? Thank you.
Do we have the speaker?
Yeah.
Sir, can
Dr. Raman?
Yeah, I think the role of PET-CT in routine diagnosis of sarcoidosis, well, it has to be selective. It has to be selective in cases where you are not able to establish the diagnosis for surety. And a one word of caution. And I will share you, those of you who remember the ACR Thieves Market case, which our resident presented in the ACR American College of Rheumatology meeting last year, was a patient who presented with hypercalcemia and had muscle involvement, had some history like Sika symptoms, parotid gland involvement and other areas, just to suggest that, and autoantibody positivity. And MANTU was negative. A muscle biopsy was done, which showed sarcoid granular mass inflammation. But we went ahead and did the PET and did biopsy because there were some skin lesions also toward the back of the leg, which made us believe whether it is something like erythema induratum. And it turned out to be TB. And it was AFB positive, there was a PCR positive, started on ATT. We tend to do a PET guided biopsy, which we do routinely when we are struck. The other form of picking up the cardiac involvement. That is where I would use PET. Although we use PET in rheumatology practice reasonably frequently, but those are the special situations where I believe that the role of PET might be there.
Thank you,
Sir wants to add.
No, I don't have anything to say.
We'll move on to the next
Thank you.
interesting case discussion. Dr. Sunita.
At the outset, I would like to thank the organizers for giving me this opportunity. My case is about a 28-year-old male. His main complaint was snoring and difficulty in swallowing. So with these complaints, he went to an ENT surgeon and he was diagnosed as having tonsillitis, and he underwent tonsillectomy. Over the 2 months, for 2 months he was doing fine, but later on he had recurrence of symptoms, and he had severe mouth breathing, especially in the nights. And ENT evaluation again showed an edematous upper airway, and he required repeated IV dexamethasone and oral steroids. This was going on for 1 year, and he was intermittently receiving 3 to 5 days of steroids, and it was coming down, but he could not get complete relief. After 1 year, there was increase in severity of these symptoms, and he had a severe dysphagia. This time, the evaluation showed that the tonsils which were removed 2 years ago had regrown, and They have also shown that the lingual tonsils were also enlarged, and this time the ENT surgeon had planned a reconstructive surgery. So when the elective surgery was planned and there was a difficult airway, so the surgery was withdrawn and the steroids were given. Next, in over 2 months, the symptoms were persisted, and he developed even obstructive sleep apnea symptoms, like he had excessive snoring and apneic episodes, and daytime sleepiness was there, and dysphagia was severe. This time, on evaluation, it was shown that there was sinusitis also, and on one night he developed severe respiratory distress and stridor. On evaluation, there was edematous supraglottis. So his sister happened to be an anesthetist, so she did an emergency tracheotomy in a near clinic. So these were her his laryngoscopic images. Here you can see the epiglottis looks like a turban epiglottis with lot of edema of the epiglottis as well as the swollen arytenoids. And there were few erosions over the epiglottis also seen. So here at this particular point of time, because he was having recurrent episodes of supraglottic airway obstruction which was responding to steroid, a rheumatology consultation was sought. So here we have a young male who had supraglottic obstruction requiring steroids, and he also had sinusitis. And on clinical examination, there was no history suggestive of any organ involvement, or clinical examination was also normal, and there were no allergies. At this point of time, these were the differentials considered. First was the ANCA vasculitis, that is vaginous granulomatosis with upper airway involvement, and sarcoidosis and IgG4 related disease. Because he was a young male and he was having a recurrent episodes of edema involving supraglottic area, hereditary angioneurotic edema was also considered. On evaluation, except for the high ESR, the routine biochemical evaluation was normal. His calcium was 8.9 and ACE levels were normal. His IgE was elevated. His immunological evaluation showed ANA, ANCA was negative, and complements were within normal limits. So he was posted for surgery, and what we did was, during the surgery also, he had desaturation because of the difficult airway. So the tracheostomy was performed, and he underwent lingual tonsillectomy, palatoplasty, and supraglottoplasty was there. And this was done under steroid cover. So the biopsy of epiglottis was showing non-caseating granulomatous inflammation suggestive of sarcoidosis. And the gene expert was negative, and the AFB was negative. IgG4 staining was also negative, and the fungal cultures were also negative. He underwent PET-CT to look for any other organ involvement, but it could show only the nodular enhancement in the nasopharynx and the oropharynx. So this is a case of a laryngeal sarcoidosis. So he has taken IV steroids during the hospital course and postoperatively for 3 to 5 days. Later on, he was given 1 mg per kg of the steroids followed by methotrexate. So he improved well. Over 6 months, we could taper the steroids completely, and he was doing fine on methotrexate. Now 2 years down the lane, he had intermittent episodes of inflammatory arthritis, and there was one time when he had lower respiratory tract infection, which was, the imaging was showing hilar adenopathy, the new onset, which was not there before. So the diagnosis in this patient is a sarcoidosis with laryngeal involvement, which was the only involvement at the onset. And he also had sinusitis, and over the due course, he had hilar adenopathy and arthritis, which had good response with steroids and methotrexate, and also he underwent reconstructive surgery. So, discussing about the laryngeal sarcoidosis, this is the least common involvement in sarcoid, constituting about less than 5%, and isolated sarcoidosis is very rare. In sarcoid, the involvement of the supraglottis is very common compared to the subglottis that we see in case of ANCA vasculitis, that is vaginous. Here we have the involvement of epiglottis, which is causing upper airway obstruction. The common clinical features include the dyspnea, dysphonia, dysphagia, and cough. the like the macroscopic pathognomic appearance of sarcoidosis when we see under the direct laryngoscopy is the thick edematous pale pink supraglottis, or we call it as turban shaped epiglottis. It is known to have relapsing and remitting courses, and which may ultimately burn out, like we have seen in this particular patient. And when we see the literature, the common association with the laryngeal sarcoidosis is the lupus pernio, which is seen in around 50% of the cases. Steroids were given in most of the patients, and other therapies include laser reduction, so the debulking and intralesional steroids. And the steroid sparing agents include methotrexate, azathioprine, and hydroxychloroquine. Few patients who have an associated systemic involvement or who had a refractory lupus pernio were given TNF inhibitors. The idea of bringing up this case is a rare presentation of a sarcoidosis involving larynx, and he almost had two emergencies requiring tracheostomy. So my questions to my doubts are like, what is your experience with laryngeal sarcoidosis, and how, when do you suspect a laryngeal sarcoidosis in a patient presenting like this?
Honestly, I have never seen such case. These are uniquely rare presentations. Although in PGI, our pulmonology colleagues see around 100 to 120 cases a year. But I have not seen anybody discussing this kind of a presentation in my 20 years experience of PGI. I mean, I can see Vishwanath coming up and standing there. So maybe, Dr. Dheeraj never showed us anything like that. Dr. Bhamri never showed it us. And nowadays we have Sahajal, who works in sarcoidosis. I think he sees more than 100 patients a year. I don't think I have seen anybody. If pulmonologists have seen and not presented in the PGI LT1, because I haven't missed many presentations in LT1, so it's pretty rare. But having said that, as Dr. Bhamri said, rare manifestation in different areas can be a manifestation with sarcoidosis. And the clue probably here also lied in the fact that the patient also had mediastinal adenopathy along with this kind of a presentation. So this will be thrown up amongst the differential diagnosis, and perhaps in such a scenario, PET is the key. The answer lies in the first case is a questionnaire, that perhaps in such scenarios we'll do PET, and either you try to take biopsies from those areas which are lighting up. Is that right, Vishwanath?
Good evening, sir. I agree with you. We have not seen such kind of presentation in the past. Actually, one question which came to my mind was whether it is ANCA negative vasculitis which is involving only the upper airway. Because
well, that question is again very difficult to answer. The only, I have seen around 450 ANCA vasculitis patients now prospectively, and I haven't seen any patient presenting like this. I looked at the radiology of patients with proven GPA and kind of tried to differentiate it from pulmonary tuberculosis. And one thing which stands out is absence of mediastinal adenopathy in GPA. So this patient had mediastinal adenopathy. So there is a soft pointer toward against granulomatosis with polyngiitis. But having said that, these isolated manifestations, people have talked about being whether they, just like the first case. Did you see the first case that I showed?
Sinonasal sarcoidosis.
Sinonasal sarcoidosis. So sinonasal sarcoidosis versus GPA. So the answers eventually will come either from, ANCA positivity and a sinus disease. If they are not, or the soft pointers are nasal crusting, nasal obstruction, nasal bleed, hearing impairment, even mild, very big oral ulcerations. You have to put the pieces of the puzzle together if the ANCA is negative. Or having a histopathology which does show there is a vasculitis besides a granuloma. Vasculitis necrosis and a granuloma, that's what would, besides this, otherwise you would just be debating. But what we've looked at our radiology is that, to cut a long story short, if you have reasonably big mediastinal nodes, we are these days doing PET scans in patients with the GPA, and if we get more information, which is more than what you do in CT, probably we'll share with you. But as of now, this is what we've seen. And some of the radiology, that in that work, Valiyappan was also associated with us from pulmonology department in PGI.
And one comment which I wanted to make is, if there is a new onset lymphadenopathy on immunosuppression, maybe it would be more prudent to look for evidence of tuberculosis, because that is also a common outcome.
Infection, that was a word of caution.
Yeah,
Two things.
but,
In the Western literature, they say if you have a acute ankle arthritis, erythema nodosum, eye involvement, and the Lofgren syndrome, you may not need to do a biopsy. That might hold true for MANTO is negative. That might hold true for Western population. We've seen patients who are MANTO negative. Our pulmonology colleague, my counterpart was Dr. Ritesh. I used to call him up and fix up the TBLBs, and he's guru of Krishna. And we've seen AFP positivity and TB in all those patients who would kind of, because Ponce's and Lofgren kind of have a very overlapping manifestation and just don't go by a MANTO negativity. In endemic country, even MANTO might be negative in disseminated tuberculosis, unless we are doing head-to-toe imaging like PET, which obviously is out of question in garden varieties. It's not possible cost-wise, logistically. You might miss a focus of TB somewhere. And we've ourselves seen TB mimicking just like Lofgren syndrome with AFB positivity and response only to ATT. And at that point, because steroid responsive, sarcoid is a steroid responsive disease. If you have new onset, this thing, and the case, all the rheumatologists know that was the best case in the world last year in the American College of Rheumatology meeting. It looked like a sarcoid myopathy, which turned out to be TB. Because as a cynic, and even we've learned from Dr. Bhatt that tissue is the issue. We were chasing the biopsies initially had shown only a granuloma. It was only during PET, and what the evidence of the advantage of PET is PET guided biopsies are done from the hot lighting up areas, from where the pickup rates are likely to be more.
Yeah, thank you very much, sir, for sharing your wisdom. Thank you, sir.
Thank you.
Thank you.
Thank you, Dr. Sinita. We have a question from the audience. From online, there is an online question. The role of AC levels and how much importance it has to be given to AC levels, and
well, for diagnosis, it has practically no role. That's what we teach our residents. It might be normal in 50% of sarcoids, and it may also be elevated in other granulomatous conditions, which probably would include TB also. It is elevated in endocrinal problems. So some people might say that it might be used for, if there is elevation, it might be used for response to therapy. But if I have to answer very, in a one word, the answer is no role in diagnosis.
thank you, sir. Dr. Jugal.
I have one question. What explains the normal?
The first thing is, okay, Jugal, please go ahead.
The presence of normal acute phase reactants in patients with widespread sarcoidosis. They have
probably that answer lies in the question which was previously asked. It's a mix of energy and inflammation. So that is why you do see rise in inflammatory markers in some subset of patients like acute sarcoid. You might have Lofgren's, you might have high ESR, you might have high CRP. Some of patients of ocular inflammation can also have rise in inflammatory markers, but not all. These are obviously not as much elevated as you would kind of, as a rheumatologist, wish to see in other manifestations of arthritis.
So does it give us a clinical clue that we should suspect sarcoidosis when the patient has a heightened inflammation with normal acute phase reactants?
Well, you should always cast your net as wide as possible.
Thank you.
And I thank you for trapping me here, and I was kind of trying to excuse myself because I was held up, but Jugal just held on to me that you have to make this presentation. So, and I hope that I didn't disappoint all of you, although it was done at a very short interval from my side.
Thank you, Professor Raman. Before we conclude, one last question from my side. So when do you think we actually require a second drug in sarcoid? Because Sunita went with an upfront usage of methotrexate.
Generally, I heard Professor Bachman many years ago in PGI. I think it was 2007, 2008. That time I was intrigued by his talk when he showed that probably a combination of 2 or 3 drugs have to be used in refractory sarcoid. The question is that perhaps the bad type 3 pulmonary sarcoid or some sarcoid which are not responding to initial therapy. Where we have used it in the pulmonology part, fortunately, is taken care by my pulmonology colleague Sajal Duria. Where we've used for a long time and perhaps more drugs than one is ocular sarcoid, because we have a close collaboration with Uveitis Clinic, and you also have a close collaboration with your friends and colleagues in, I think, LB Prasad. Perhaps that is the situation where we ended up using more of a combination therapies or multiple drugs sequentially, and some people even requiring anti-TNFs to control ocular infection, especially the posterior segment involvement. Fortunately, the rheumatologist, if they see only arthritis, the acute Lofgren responds very beautifully Some of them even might respond just NSAID. So we don't really see that subset as pure rheumatologists. But when you are working in collaboration or in combination with other specialties, that's where you would have to use. And there are some manifestations like liver involvement and all, which are very refractory to therapy. So those are the few situations which come to my mind offhand based upon our.
Yeah, one last question from Sharat.
Yeah, regarding the same actually. So I have a couple of cases of CNS involvement where the patient was resistant to a single drug. So we had to use anti-TNF along with that. And I think this is the only session we have for rheumatologists from Raman. So I want to give one, what is your thoughts about managing sarcoid by a non-rheumatologist? Because in my practice, if we say cross referral from other departments, a sarcoid case managed by a non-rheumatologist, we always say that they depend only on steroids. They use steroids, after 6 months they taper down, and again the patient gets a flare, again they restart. And all these patients, they develop steroid-related complications. But as a rheumatologist, we always use DMARDs along with the steroids. What is your message to the non-rheumatologists?
I think I concur 100%. The two comments that I wish to make. One is that whenever you make a diagnosis of sarcoid, we have to exclude the other common differentials which include infection also. That's point number one before we start treating them with immunosuppression. Once we've decided that we have to give immunosuppression, unless very small, the first steroid sparing drug has to be used in most of the conditions where you know that steroids have to be used for a long period of time, which perhaps we as rheumatologists are attuned to, what we call as steroid sparing agents. And we can't just solely rely, say for example, if you have various organ system involvements wherein you the one drug which has to be used which blocks antigen presentation, like in chronic arthritis, is hydroxychloroquine. The other good drug is methotrexate. We can, I agree with you 100%. Where we feel that there is a major internal involvement, the use of steroid sparing drugs should be probably upfront, so that we can take care of the steroid burden much faster, so that we can prevent all kinds of problems which Dr. Vikas showed can occur because of steroid use, which is prolonged over a period of time in sarcoidosis.
Thank you, Dr. Raman.
And
Thanks, Raj, and thanks, Dr. Varaprasad, for your patient hearing. And thank you, the audience.
Thank you.
And thanks, the organizers.
Yeah, thank you
And
very
thanks,
much.
Jugal, for this invitation.
To sum up, as a rheumatologist, we are more inclined towards using more DMARDs upfront along with steroids, and we try to bring down the steroid as soon as possible, because we use these DMARDs quite often, day in and day out. Thank you, Professor Raman. And with this, we conclude this wonderful session. I thank our speakers, Professor Raman, Professor Vikas, and Professor Pradeep, and over to Madhuri.
Sir, on our organizing committee behalf, we would especially like to thank Professor Bambri and Professor Aman Sharma for staying through the session and giving us such enlightening tips. And I think
thank you, madam, and thanks, Professor Rao, for giving us this opportunity to share the platform with the AIG team. Our gastroenterology colleagues always keep on talking about AIG, so it's also good to interact with the AIG team. Thank you very much for the kind invitation.
We hope to see you in person, sir, next time.
Sure. Whenever Raj and Varaprasad and Jugal literally held me, I was trying to excuse myself, but then he held on to me that you must, and hopefully I could put some things together for discussion. Thank you very much for your patience.
Thank you, sir. Thank you so much. Thank you to our audience too for participating. I would just like our moderators to please give a certificate of appreciation to our case presenters, Dr. Sunita and Dr. Amrita, please. Dr. Amrita, you can please come. Dr. Rajkiran, sir, if you can please present the certificate of appreciation. Thank you, Dr. Amrita. She is a final year DNB resident at KIMS Secunderabad, being trained under Dr. Sharat Chandramouli. Dr. Sunita is a consultant rheumatologist at Yashoda Malakpet, and we thank both of them for presenting their cases in this session. We thank our moderators too for being here to guide us through these sessions. We now have a short tea break and we will start our next session on basic and translational sciences sharp at 5 p.m. Please join us after the tea break.
Hello, it's Bob Hoffman. Hello, this is Bob Hoffman.
Hello?
Yeah, this is Dr. Hoffman. I know Dr. Krohn was on a different Zoom thing and she could not get in.
I think Dr. Trump is also joined us.
Is the session starting now?
Yes, 5 minutes.
Yeah, you need to, I think you may need to send a note to Dr. Krohn, who's the first speaker. Yes. Oh, she's just come in now. Okay. Hello, Dr. Crown. Crown, good morning.
Good morning. How are you?
Pretty good. You're
Good.
like me trying to figure out what's going on here.
A few minutes ago, I logged in and saw the speaker speaking, so I think it's hopefully people aren't watching this conversation, but I could see the speaker and could see what was going on. So I think this is a good link. I hope.
Yeah, I met briefly with somebody else and then he's come off again. So I think we're in the right space. We'll see.
Good morning.
Thank you. Okay. And
Good morning.
Manisha.
Hey.
We're doing well here. Got pretty much everybody.
Dr. Bachman, how are you doing?
Very well, thank you. Yourself?
Good. In Jordan, I have met you, Manish Bhargava. I'm at University of Minnesota.
Nice to meet you.
Yeah.
And Dr. Crown, I want to thank you again for your nice review for the sarcoidosis. I think it just got published.
Thank you for publishing it. We're really, it's really fun to work with our sarcoidosis team. It's been really fun over the years, and I really wanted to write something with the group. So thank you for publishing it. It was really fun to write.
You did find it, right? Because I think it just got published.
I've seen it online.
Yes, that's all it's going to be. We're only an online version of the journal. So.
Okay, perfect. Yeah, it sounds great. And I'm showing a couple slides from that today, talking about collaborative care. So.
Great. Good luck.
Garva, how is the weather there? Is it getting cold up there already? Is it winter time or still cold?
So I'm sitting in my basement, and just before I got down here, my wife told me that it's snowing outside. So this is the earliest I've seen it snow, and probably just a few snowflakes today.
Wow. That's a little early.
I'm not ready for it.
Right now I'm in Chicago, so I guess that's what we're going to get a little bit more of that. Hopefully not the snow yet today.
Yeah, is it cold there?
It's pretty cold, but it's not. There's no snow on the ground that I can tell. Actually, it's not. It's pretty clear.
We're in Virginia. Fall is like the season. We have the beautiful leaves changing. The weather is anywhere between like 60, sometimes 70 degrees. We're sort of. I don't want to brag, but the weather right now is pretty good for a few weeks. But we don't get any good snow in the wintertime.
Fall is the best time of the year for me. A little crispness in the air, and the days are cooler. You can do a bunch of stuff outside.
Yeah.
Sir, 30 seconds. Sir. Ashwat sir just joining.
Dr. Ravikant. Good evening, friends, and good morning to our esteemed faculty. We would like to get started. May I just request Dr. Ravikant from the research lab. Dr. Ravikant is a PhD in genetics from the university, and he's currently heading the genetics division of this institution. And I would like to call upon Dr. Sashidhar also, who is in charge of our basic science lab. Sashidhar, can you just join us? And Dr. Ashfaq, thank you for joining. And I would like to thank our esteemed chairpersons and distinguished faculty for making this possible. Deeply grateful for Dr. Jordana Kron, Dr. Bhavman, and Dr. Manish for joining us early in the morning. What time is it? 5 a.m., 6 a.m.? I'm deeply grateful for making this possible. May I just kickstart the program with the first talk by Dr. Kron, who's done a remarkable work in the field of cardiac sarcoidosis. Like everything in medicine, the organs don't confine themselves to a particular organ. It's a multi-system involvement. And increasingly we find that the care for our patients is not equitable. And she has done a remarkable work in setting up a cardiac sarcoid consortium, which has helped to address both these issues of increasing the awareness about cardiac sarcoid and have a very, very collaborative approach in terms of data collection and furthering research in this area. And it's indeed a great honor to invite Dr. Jordana Kron, who is currently the Professor of Medicine at the Virginia Commonwealth University, to talk about collaborative approach to sarcoidosis treatment and research. Jordana, please.
Hi, I'm Jordana Kron from Virginia Commonwealth University. First, I want to thank the organizers of this summit for inviting me to speak here today. I'm delighted to be here. Today, I'll be speaking on cardiac sarcoidosis, collaborative approaches to treatment and research. While I have no disclosures, I do have some research funding to talk about, which includes the study that I'm going to speak about at the end is supported by an NIH R21 grant and an American Heart Association Collaborative Sciences grant. My research has also been supported by our Center for Clinical and Translational Research, which has a CTSA UL1 grant. My talk will be in two parts. First, I'll be speaking about collaborative clinical care. Following that, I'll talk about the importance of collaborative research. A lot of what I'm going to speak about clinically today will focus on our sarcoidosis clinic. More than 10 years ago, several providers in our hospital got together and were concerned about the difficulties of caring for complex sarcoidosis patients. We decided to build a clinic to provide multidisciplinary care. We were very excited to be recognized by WASOG as a sarcoidosis clinic in 2017 and a center of excellence in 2019. This is the model of our collaborative clinical care. And the most important thing about this slide is that the patient is the center. We really want to provide excellent patient-centric care. Now, this does not represent every specialty that may be needed, but you can see the centrality of rheumatology. These specialists help manage immunosuppression and monitor for drug side effects. The pulmonologist, who works to prevent end organ damage and reduce symptoms. Cardiac electrophysiology, who can identify the risk for ventricular arrhythmias and sudden death. And then, of course, all of these other specialties and more are very critical to managing these complex patients. These are the 4 pillars that we've identified that are critical for a sarcoidosis center. Over here, we have clinical care aimed at reducing mortality and improving quality of life. Communication between providers and from the providers to the patient is very important to improving outcomes. We also think this multidisciplinary approach can help reduce healthcare disparities. Down here we have research, and a multidisciplinary clinic can be used to help recruit patients to participate in ongoing research and future clinical trials. Teaching is very important to help disseminate current best practices and train future providers. Finally, community engagement is very important to help improve the patient experience. It can decrease feelings of isolation and anxiety and improve skills to cope with challenges. By providing one-stop shopping, a sarcoidosis clinic can help improve the patient experience and also improved cost efficiency. When patients come, they can see multiple providers at one time and also get testing. This reduces important barriers for patients that can include financial, time, and transportation barriers. Here's some data that is not from sarcoidosis, but is from multidisciplinary care for pancreatic cancer patients. These are patients, 162, that were referred for surgical treatment for pancreatic cancer. You can see here on the left that patients are divided into high socioeconomic status and low socioeconomic status. When patients were just treated by routine care, there was a significant discrepancy in survival. In contrast, patients that were treated with multidisciplinary care had removal of those discrepancy in outcomes, so that patients with low socioeconomic status had improved outcomes. The thought is that by improving and standardizing treatment decisions and making it a standardized approach for all patients, we can minimize these healthcare disparities. Teaching is very critical to engage learners at multiple levels of training, and this is something we do every week in our clinics. We highlight the importance of communication with the patient and family, communication with other healthcare providers, and awareness of the healthcare disparities that can lead to poor outcomes. We also highlight the importance of screening for extrapulmonary disease, particularly eye disease that can lead to vision loss, and cardiac disease that can lead to life-threatening arrhythmias. Research has identified several important barriers to care. These include perceived inadequate knowledge about sarcoidosis among providers, so patients identifying that their providers are not comfortable with current sarcoidosis treatment, communication barriers with providers, and the high cost of treatment. So interventions can be targeted at patients that may improve these socioeconomic disparities. Community engagement can be used to promote self-management. We can use education to focus on symptom recognition, treatment options, and side effect management. We want to provide educational programs that are available to patients regardless of socioeconomic status. We've been very lucky to partner with the Foundation for Sarcoidosis Research that has a lot of campaigns focused on engaging the community in education. This is one of many, many different campaigns they've had, but a very recent one that was called Ignore No More. And this was focused on educating providers and patients on the poor outcomes that are suffered by African American women with sarcoidosis. African American women have more severe and chronic forms of sarcoidosis and have higher rates of hospitalization and mortality. At this point, I'd like to switch over and talk a little bit about some of our ongoing research collaborations. In 2011, several centers joined forces to try to improve research within the realm of cardiac sarcoidosis. In 2011, the Virginia Commonwealth University, University of Michigan, and University of Colorado got together and wanted to improve the way that we did research in cardiac sarcoidosis. We formed an international multi-center partnership among physicians and allied professionals at major medical centers with a unifying purpose to learn more about cardiac sarcoidosis through collaborative research. We had our first meeting at the Heart Rhythm Society conference in May of 2012. The initial efforts have been at building a prospective web-based registry that is founded at the University of Michigan. Here's our Twitter page, and I encourage you to follow us on Twitter at CSC Registry. Here we highlight a lot of ongoing research, not only in cardiac sarcoidosis, but in sarcoidosis more broadly. The mission statement for the Cardiac Sarcoidosis Consortium has 5 main pillars that we focused on. First, we want to create a model for multidisciplinary care for cardiac sarcoidosis patients. We want to improve quality of life and clinical outcomes for patients with cardiac sarcoidosis, identify and eliminate healthcare disparities, further the understanding of pathophysiology, clinical presentation, and treatment. And finally, something that's been very important to my work is to establish a global community of researchers committed to understanding of cardiac sarcoidosis. So while we started with the prospective registry, it was always a goal of this consortium to build the infrastructure to perform randomized clinical trials. And we're still at the very initial stages of doing this, but we can see that we're building the infrastructure where we're going to be able to perform these randomized trials. So here's the map that shows all of the different contributing centers. And we're so grateful to all of these centers who have really put a lot of time and effort into recruiting patients and collecting data. We have a lot of centers in the United States, but also centers in the UK, Netherlands, Sweden, Japan, and India. I'd like to call out the Care Hospital here in Hyderabad for being a contributor to the consortium from the very beginning, and we're very grateful for their contributions. I'd now like to present some of the findings that we've had from this consortium. And it's important to note that the data we've found would not be possible without this collaboration. This is simply not research you can do from one center and a small number of patients. So this is important data published by Frank Bogan from University of Michigan, looking at 158 patients with cardiac sarcoidosis within the consortium. 33% were female, mean age was 52, and about half of patients had an ejection fraction less than 50%. This data comes from 16 international centers nested within the Cardiac Sarcoidosis Consortium. The primary outcome was a composite of VT recurrence, heart transplant, or death, and the median follow-up was 2.5 years. Probably the key finding of this study was that in patients with VT storm was eliminated in 82% of patients. ICD shocks were also significantly reduced post-ablation. Unfortunately, long-term survival free of these primary endpoints was still not excellent. 1 and 2 year survival free of the endpoint were 60 and 52% respectively. So let's look at this data a little more closely. In this first figure, we look at ICD shocks before and after VT ablation, and you can see that shocks were significantly reduced in these patients. Over here on the right, we look at outcomes divided by heart function. And so you can see in yellow that patients who had an ejection fraction less than 50% had more recurrence of VT, heart transplant, or death than patients who had preserved left ventricular function. Over here we see that patients who had ongoing inflammation did worse than those who had no inflammation. Here's some data that was just published this year in JAHA. And there was an electrophysiologist, Dr. Bressi from Rome, who helped us put together this important data. Of the 587 patients within the consortium who met diagnostic criteria, 164 patients, or 28%, had worn at least one Holter monitor. The key finding of this study is that arrhythmias are very common in this population. 34% of patients had non-sustained VT on Holter, and 22% of patients had at least 5% PVCs. Other data we found is that, looking over here at non-sustained VT, patients that had a lower ejection fraction, shown in black, had more non-sustained VT than those who had a preserved ejection fraction, shown in gray. And down here we see that overall, males, shown in blue, had more arrhythmias than females, shown in red. And then finally, when we look at adverse outcomes, which include death, left ventricular assist device, heart transplant, or appropriate ICD therapy, we see that patients who had VT, and this included non-sustained VT or PVCs, had worse outcomes overall than patients who didn't. Here's some data that was put together by a summer student. This was an undergrad summer student I had who was sponsored by the American Heart Association and was presented at our summer conference. And she really looked at comorbidities in cardiac sarcoidosis by region. As way of background, we know that patients with cardiac sarcoidosis and sarcoidosis in general have worse outcomes when they have comorbidities, including hypertension and diabetes. When we look at comorbidities, we see that they are high across all comers in the consortium, but they are particularly high in the United States. We broke down the United States into different territories, including the Midwest, Northeast, Mid-Atlantic, South, and West, and grouped patients in Europe and Japan. And you can see, looking at hypertension, that within the United States, 4 out of 5 regions had hypertension rates that were over 55%, which is really quite shocking. Also, within the United States, but in all comers as well, rates of diabetes, shown in orange, were also very significant. I'd like to take the last few minutes of this talk to focus on ongoing randomized clinical trial. Now, this is a pilot study that we're performing at Virginia Commonwealth University and University of Michigan. And I think this trial is very important. While this is a small pilot study, it's very important for the infrastructure that it is building for future, larger, randomized clinical trials. Interleukin-1 is a pro-inflammatory cytokine that is released in response to an injury signal. This typical sort of, classic cytokine plays a role in atherosclerosis, acute MI, and heart failure. And there is also basic science evidence that it plays a role in granuloma formation. We looked at the activation of interleukin-1 in patients with active cardiac sarcoidosis. So these are patients who had known active sarcoidosis, shown on a cardiac PET scan, and underwent surgery, either heart transplant or left ventricular assist device, because of their sarcoidosis. We then took the surgical specimens from transplant or LVAD and stained it for the inflammasome, and this is shown in red here. Now, the inflammasome is a macromolecular structure that produces interleukin-1 in response to an injury signal. So you can see here, this is the first evidence of inflammasome activation within granulomas in patients with active cardiac sarcoidosis. So this is sort of the basis for our rationalization that interleukin-1 may be playing a critical role in the pathogenesis of cardiac sarcoidosis. Here's our trial design, and we call this the Magic Art Study, the multimodality assessment of granulomas in cardiac sarcoidosis, anakinra randomized trial. Anakinra is an FDA-approved interleukin-1 blocking medication. In this pilot study, patients with cardiac sarcoidosis and evidence of active sarcoid on cardiac PET scan are randomized to anakinra for 28 days on top of standard of care or standard of care. The key biomarker that we're looking at is C-reactive protein. C-reactive protein is known to go up and down with interleukin-1 activation and also correlates with excellent outcomes in many cardiovascular trials. So here I'd like to show you our preliminary data. We are still enrolling in this trial, and we did an interim analysis. And this data was presented at the American College of Cardiology earlier this year. Importantly, as this was also a feasibility trial to show whether we can even enroll patients with cardiac sarcoidosis in a clinical randomized trial, we have randomized 16 patients from 2 centers. Importantly, 56% of patients were self-identified Black or African American, and 75% are women. Patients were randomized to either anakinra and standard of care or standard of care. Patients had no unexpected adverse events. 43% did have self-limited site reactions, which is known to be a common occurrence in patients receiving anakinra. No patients had to stop treatment because of this reaction. You can see in this graph that patients who were treated with anakinra had a significant reduction in 28-day C-reactive protein than patients who were on standard of care. And this p-value at interim analysis was significant at 0.029. So we found in our initial data from this randomized clinical trial the feasibility of recruiting and enrolling a diverse population of patients with cardiac sarcoidosis, safety of targeted anti-inflammatory therapy with interleukin-1, anakinra, and we feel this is really an important trial, not only for what it is demonstrating, but for the approach to this very understudied rare disease. So it gives us hope for the future that we'll be able to design more trials like this. I'd like to show here in our multiple different clinical studies, we've been able to recruit patients who are both women, more than 50%, and African American. And it's very important to include these patients in our trials. So in summary, I'd like you to take home these points. There are 4 pillars of patient-centered sarcoidosis clinic: clinical care, research, teaching, and community outreach. Creating healthcare and research infrastructure may help to decrease healthcare disparities and improve outcomes in our sarcoidosis patients. Finally, recruiting and retaining diverse research participants in sarcoidosis trials is critically important to understand the disease process in patients who are most adversely affected. Thank you so much for having me here today, and I welcome any questions. Thank you.
Thank you very much, Dr. Tran. Truly appreciate the work that you're doing. And we'll have the other talks and then come back to your question if it's that okay with you. Next speaker will be speaking on genes and environment in sarcoidosis. I would like to thank Dr. Durga Prasad Mishra for accepting this task at a very short notice. And I'll ask Dr. Ravikant to introduce Dr. Mishra.
Good evening, everyone. I take the privilege of introducing the next speaker, Dr. Durga Prasanna Mishra from SGPGI Lucknow, who has had a very remarkable career with lots of international and national awards. More importantly, his research work, both clinical and basic science, resulted in around 150 papers in peer-reviewed international and national journals, which was supported by funds from Asia Pacific League of Associations for Rheumatology and the Indian Council of Medical Research. I thank him for this talk, and over to Dr. Mishra.
We have the talk by Dr. Mishra played.
Good evening. I am Dr. Durga Prasanna Mishra. I am Associate Professor of Clinical Immunology and Rheumatology at SGPGI Lucknow. The topic allotted to me is genes and environment in sarcoidosis. At the outset, I would like to thank the organizers for giving me the opportunity to speak on this topic. I do not have any disclosures. So we shall briefly have a look at the genetic factors influencing the onset of sarcoidosis. What are the various environmental factors affecting the risk of sarcoidosis? We shall see some examples of how interaction between gene and environment drives the onset of sarcoidosis in certain specific instances before we conclude. So, to start with, we all know that immune perturbations are a key factor driving the pathogenesis of sarcoidosis. Antigen presenting cells through MHC class II molecules present the antigen to the T lymphocytes, thereby activating them and leading on to secretion of interferon gamma from the T helper 1 lymphocytes and tumor necrosis factor alpha from macrophages and other cells. And this leads on to the formation of a granuloma, which can either resolve or can go into a chronic fibrosing phase. Also, a dysfunctional response of T regulatory lymphocytes has been observed, which allows the inflammation to go on unchecked. There are various genes predisposing towards sarcoidosis, and not surprisingly, many of them are in the HLA group, which influence the presentation of antigens to elicit T cell responses. There are also genes involved in NK cell activity, hydrolase activity, regulation of T cell activation, and the genetic predisposition also differs with respect to the population. For example, HLA-DRB1 O401 predisposes to ocular sarcoidosis in African Americans, whereas DRB1, 1101 and 1201 predispose to sarcoidosis overall in European Americans. The BTNL2, which regulates T cell activation, predisposes to sarcoidosis but without uveitis. And there are some protective genes as well, such as this gene ANXA11, which is involved in calcium signaling, vesicle trafficking, and cell division and apoptosis. Also, some genes involved in the cytochrome P450 pathways. Genes involved in interleukin 23 receptor, transforming growth factor beta 3. These are also involved in the susceptibility to sarcoidosis. Some genes are associated with prognosis, such as the LILRB4 gene, which encodes for the leukocyte immunoglobulin-like receptor family and predisposes towards a good prognosis. So, all these various genes are also influenced by the environment. If we look at the prevalent literature regarding the epidemiology of sarcoidosis, this was a paper published in 2019, which tried to take into account all the available literature on sarcoidosis in different parts of the world. The left graph shows incidence levels. As you can see, incidence data is available for a relatively fewer number of countries, but prevalence data is available for a larger number of countries, and there are wide variations in the prevalence of sarcoidosis based on geographic region. For example, one of the highest prevalent areas like Russia, Argentina have a relatively lower prevalence. So again, this might suggest that there are certain environmental influences in these areas which either predispose towards development of sarcoidosis or provide a protection against the development of sarcoidosis. Further, in this same paper, they looked at the differences in hemisphere. They summarized the data from the northern hemisphere and from the southern hemisphere. And overall, the number of patients, if you took a ratio from the southern to the northern hemisphere, that were described in the literature was 1:176. So it was much more common in the northern hemisphere. However, this must be taken with a pinch of salt because one of the key countries or continents in the southern hemisphere is Africa, from which very little literature is available regarding the prevalence of many chronic diseases, many autoimmune diseases, including sarcoidosis. Here they have looked at the distribution of the radiological stages as ventation between cohorts from different parts of the United States of America. And here, as you can see, in the Midwest cohort, parenchymal fibrosis is much more common than it is in the Northeast cohort, where lymphadenopathy on X-ray is more common and it's more evenly distributed in the southern cohorts. Again, with respect to the clinical manifestations, you can see a more dispersed distribution of cutaneous ocular lymphadenopathy and hepatosplenomegaly in the northeast cohorts, whereas in the midwest cohorts, cutaneous and renal involvement with hypercalcemia were the dominant manifestations. In the southern cohorts, again, cutaneous, ocular, and hepatosplenomegaly were the dominant manifestations. So again, where the disease has been detected also determines to some extent what are the clinical features, suggesting that maybe environmental influences in these different parts of the world may play a role. This is another analysis from the same paper where they have analyzed the prevalent clinical features in Japanese, Chinese, and Indian cohorts. As you can see in the Indian cohorts, pulmonary fibrosis is little uncommon. It's mostly either lymphadenopathy with or without parenchymal involvement. Whereas in the Japanese cohort, pulmonary fibrosis is relatively more common, so also in the Chinese cohort. And again, parenchymal and lymph node involvement are most common across the three regions. With respect to clinical features, ocular features are more common in the Japanese cohort, much less common in the other cohorts. In the Chinese cohorts, lymphadenopathy and renal involvement with hypercalcemia are more common. In the Indian cohorts, hepatosplenomegaly was more common. So again, variations in these manifestations based on where these patients are from. They again looked at the correlation of these different parameters such as the gender ratio with the ethnicity. So as you can see, the proportion of females is more if the ethnicity is African American, and it's the opposite when it's a white ethnicity. Pulmonary fibrosis is more in African Americans. Cutaneous involvement is also more in African Americans. And in the whites, ocular involvement is less common. So there are differences based on the ethnic group, and these obviously are of a different genetic background. So this suggests that both the gene as well as the environment play a role in the predisposition to sarcoidosis. Again, here they have looked at the various radiological stages and the organ involvement in white population, Asian population, and African American population. As you can see, the stage 4 disease is much more common, that is pulmonary fibrosis is much more common in African Americans, much less common in the other two cohorts. And similarly, stage 2 disease is more in the white and African Americans, lesser in the Asians, who have more of a stage 1 disease, that is simply a lymphadenopathy. Here again, the different clinical features. Whites tend to have more cutaneous involvement. African Americans tend to have cutaneous, ocular, and hepatosplenomegaly. Asians tend to have more of ocular involvement. So again, ethnicity to some extent determines the kind of clinical features that you encounter in patients with sarcoidosis. And this was an analysis which suggested that a greater proportion of females, this shows you the proportion of females greater proportion of females were found to have sarcoidosis in between the latitudes of 30 and 45 degrees, again suggesting the role of environmental influences. The seasonality and incidence of sarcoidosis also differs by geographic location. In the more northern areas, the onset is more common in the winter months, whereas as you go towards the equator, it starts to become more common in the spring months. And in Japan and India, it's actually more common in the summer and autumn. So again, a definite gradient is seen as you go across the latitudes. And again, in New Zealand, what the prevalent literature suggests is that it's more common in the winter and the spring. Putative agents that have been implicated include Mycobacterium tuberculosis, other mycobacteria, Propionibacterium acne, fungi, Borrelia, based on either immunologic evidence or molecular evidence, less commonly cultured evidence. Again, this just summarizes the environmental influences and the differences in prevalence in certain time periods as well as in certain areas. And this shows the influence of occupation. For example, firefighters who were exposed to the World Trade Center, the dust arising from the collapse of the World Trade Center buildings had an increased incidence. And similarly, other different occupations have been associated with risk of sarcoidosis. Certain environmental exposures such as wood stove and fireplace use also associate with increased risk of sarcoidosis. With a dose response curve, more the dose of exposure, the greater is the risk. This summarizes the occupations and risk of sarcoidosis. For example, metal automotive workers have a higher risk, whereas welding and gold workers have a lower risk. So how do gene and environment interact? This was a study of 3,713 patients from Sweden who either had Lofgren or non-Lofgren sarcoidosis. And here they have looked at the risk with different polymorphisms, the risk as it is influenced in the presence or absence of smoking, and they have calculated the attributable proportion. And as you can see, the attributable proportion due to smoking is quite high, up to even more than 0.6 for the presence of certain genes. So in the presence of certain genes, both for Lofgren and non-Lofgren sarcoidosis, smoking increases the risk further. Again, another elegant example was from the World Trade Center firefighters, wherein they categorized them on the basis of when they arrived on the scene. Arrived in the morning of 9/11, afternoon of 9/11, on the next day, or on the days thereafter. And you can see those arriving in the afternoon of 9/11, when the dust was the maximum as the buildings collapsed, had actually the greatest proportion of events of sarcoidosis. And here actually they tried to classify the exposure to a high exposure index or a low exposure index. Those with a higher exposure had a standardized incidence ratio that was nearly 1.5 times of those with a low exposure index, although these confidence intervals were overlapping and the differences were not statistically significant. Further, when they looked at the genetic background in these World Trade Center firefighters, they discovered the influence of various genes involved in T cell signaling, involved in T regulatory responses. However, when they looked at the influence of the potential dose of exposure and the genes, they could not identify an interaction in this particular study, which led the authors to hypothesize that exposure to the dust was a more important factor driving the onset of sarcoidosis in this group rather than the dose of exposure. So to summarize, the phenotype of sarcoidosis varies with geography and ethnicity. A variety of environmental influences associated with sarcoidosis, and elegant examples of the association of smoking and genetic risk factors and World Trade Center firefighters help us understand the gene-environment interactions that drive the pathogenesis of sarcoidosis. Thank you.
Thank you very much, Dr. Mishra. I think we had a wonderful summary. We'll please stay behind for the Q&A towards the end of this session. May I request Dr. Ashfaq Hassan, who is the chair and the dean of professor of medicine at the university here, to introduce the next speaker, Dr. Manish Bhargav, please. Ashfaq, you are not audible. Can you unmute yourself?
Yeah, I have unmuted. Am I
Yes,
audible now?
yes, now it's fine.
So thank you, Dr. Simon, and my special thanks in advance to Dr. Manish Bhargava, because he is the associate professor of medicine, division of pulmonology, allergy, critical care, and sleep medicine at the University of Minnesota Medical School. And he has obviously some very, very important benchmark papers on sarcoidosis. But my profuse apologies to him is because I have hounded his every step until he has finally agreed for this conference, and I thank you very much for that. Dr. Manish, I hand over to you for your lecture. Dr. Manish.
Good evening. Over the next 10 to 15 minutes, I will share the work we are pursuing in pulmonary sarcoidosis. This work is important for several reasons. First, lung involvement is very common in sarcoidosis. What makes it challenging is that spontaneous remissions occur, and despite that, 20% of people with sarcoidosis will end up with progressive pulmonary disease and fibrotic changes. The knowledge about mechanisms driving progression is limited, but would be critical for identifying biomarkers and treatment targets. But before I proceed, I would like to thank the organizing committee for the warm invitation and getting together such an excellent program. For people who are involved in clinical care of sarcoidosis patients, the disease heterogeneity is the biggest challenge. This table represents the organ system involvement using the 2014 VASOG organ assessment tool in 187 patients we saw in our clinic. Majority of the patients, 98%, had lung involvement. The other common organs involved were skin, liver, eye, and spleen. Surprisingly, 10.7% patients had cardiac disease. We think that our cohort is ideally suited to investigate high-risk manifestations of sarcoidosis that were identified in a white paper published now several years back. Today, I'll just focus on our work in lung disease. There are tools which can predict progression of pulmonary sarcoidosis. As an example, scattering stages can predict outcomes. In two independent studies published in mid-60s, one from King's College Hospital in London and the other from Mount Sinai Hospital in New York, patients with stage 1 sarcoidosis at 5 years of follow-up generally did well. Majority of the patients had either complete or partial remission, with only 7% of the cases having progressive disease. Majority of the patients were asymptomatic. In contrast, patients with stage 2 or stage 3 scattering sarcoidosis tended to do worse, more so for stage 3 disease than stage 2 disease. The proportion of cases with complete remissions or partial remissions was much smaller, the mortality was higher, and more frequent worsening was noted. Why some people with stage 2 or 3 pulmonary sarcoidosis have remissions, spontaneous or treatment-induced, and others have progressive disease is unknown. Based on our hypothesis, the critical first step is to get a better understanding into the biological mechanisms involved in progression of pulmonary disease. Short of studying lung tissue samples themselves, BAL cells are an excellent ex vivo model system to examine changes of inflammatory conditions in the lung. A previous study by Silva used alveolar macrophages and reported differences in phagocytic and oxidative phosphorylation pathways in sarcoidosis. For our proof of concept work that I will show today, we examined mixed BAL cell populations from 4 healthy controls and 4 sarcoidosis cases. The mean white blood cell count for sarcoidosis cases was around 100 with 35% lymphocytes, and the CD4-CD8 ratio was 6.5. All of the sarcoidosis cases were undergoing diagnostic workup and were not on any treatment. We undertook high-resolution mass spectrometry studies using label-based proteomics, and our depth of protein coverage was good. We identified around 4,500 proteins at a stringent 1% false discovery rate, of which quantitative data was available in close to 3,800 proteins. 273 proteins showed differential abundance using false discovery rate method for statistical significance. 130 odd proteins were high in sarcoidosis, and close to a similar number were more abundant in controls. And this is a heat map which shows distinct changes in controls versus sarcoidosis. Each row represents a protein here, and each column represents an individual case. How do you infer biology from such a data set? One way is to look for coherent organization in your data. And the common principle which people use is guilt by association, which essentially means if there are changes in certain features, whether genes or proteins, in a similar pattern, that is overexpression or underexpression, those genes or proteins are probably involved in a common function. There are several ways to assess that. Gene set enrichment analysis is one of them. We chose to map the differentially abundant proteins onto canonical pathways shown by each solid circle here, which we will call a node. And then identifying shared behavior between the nodes, which we looked by presence of co-expressed proteins in these canonical pathways. Each line indicates relationship between the node. You can build pathways such as this one, where you find that majority of the nodes has small number of connections, and only a small number of nodes are highly connected. This behavior, where only a small number of nodes are highly connected, is called scale-free behavior. This can be illustrated in these two maps. Here on the left is a scale-free map of the airports in India, as opposed to the roadways map on the right. The airport map indicates that there are a small number of nodes which are highly connected, and the roadways map indicates that most of the cities have similar number of connections between each other. The implication of scale-free maps, such as the airline map, biological networks, social networks, they all behave the same way, is that if a highly connected node is disruptive, it will lead to loss of network function. So if the airport in Delhi is not functional, there will be widespread disruption in the commercial airlines, as opposed to a place which has only a single edge, which will cause less disruption in the network function. The implication of this for biological networks is to identify the key nodes which drive disease progression. So if we look at our data set, these are the canonical pathways which map to differentially abundant proteins in sarcoidosis versus control comparison. And there are several pathways which have been previously studied in sarcoidosis. But are they organized in a certain manner? We explored shared behavior and found leukocyte extravasation signaling is highly connected. There are other nodes which are highly connected, including IL-8 signaling, IL-K signaling, and acute phase reactants. This could indicate that these highly connected pathways may be important in sarcoidosis progression. We then looked at bronchoalveolar lavage fluid because it should be different than cellular fluid, BL cell protein expression. And for these studies, we compared healthy non-smoking controls with sarcoidosis patients. Sarcoidosis subjects were at initial evaluation and were not on therapy. And based on PFTs, chest x-ray, and need for therapy over time, they were divided into progressive and non-progressive disease. Other investigators have used this classification of pulmonary sarcoid progression and identified several genes, including CXCL9 and TCR-mediated pathway as drivers of sarcoid progression. For this work, we removed cells and debris and examined the cell-free supernatant. And we found several complex networks in this comparison. But there were three subnetworks which were obvious. One involved metabolic pathways, another involved coagulation and complement, and the third one involved immune pathways. Here are the nodes in each of these subnetworks. It is interesting that aryl hydrocarbon receptor signaling is involved because it is also implicated in particulate-induced lung diseases, such as air pollution-induced lung diseases. IL-8 cavular-mediated endocytic signaling were again identified as critical canonical pathways based on their connectivity. When we did a similar comparison for progressive versus non-progressive pathway, we found several immune pathways, and the critical nodes included CD28 signaling, glycerin-mediated endocytic signaling, and CDC42 signaling. All of this is very interesting, but most of these studies are done on small number of patients, and we are planning to repeat them with a larger sample size. But another way to validate what we find here is to see if others have reported similar findings. And for that, we identified all published studies using transcriptional and proteomics tools, and if the data set was available for a meta-analysis, which is shown here. My apologies that this is a somewhat complicated and busy slide, but each column is an individual study, and each row is a canonical pathway. Dark green tile indicates lack of statistical significance of a particular pathway in that study. For example, the first row, Th1 and Th2 activation pathway, were not statistically significantly enriched in 4 studies that we looked at. All of these studies are constrained by sample size, but the other thing which we noticed was that majority of the studies to date compare controls and healthy control, controls, sarcoidosis and healthy controls, and only a small number of studies compare some form of sarcoid subtype, such as progressive or non-progressive disease. So what did we find? We found that a number of well-established pathways were identified in a substantial number of studies. As an example, mTOR signaling has a lot of interest these days, especially because interventions are possible to interrupt this signaling pathway. mTOR signaling was present in several different studies. However, we also identified several studies which are not well, several canonical pathways which are not well studied in sarcoidosis. PD-1, PD-L1 signaling as an example, IL-8 signaling, and others. The message from this work is that most studies today are constrained by sample size, but they are important signals which can be easily detected with such a meta-analysis. And the studies using protein changes, examining protein changes are limited. Shifting gears a little bit and showing you some unpublished work in the last 6 to 8 months where we used a clever technology called proximity extension assay. This work was done in blood using sarcoidosis patients. PEA uses DNA oligomers which are combined to antibodies. And for each antigen, there are two different oligomers which identify different epitopes. And if the two epitopes are identified, there's hybridization of the oligomer resulting in color. The more the color, the more is the abundance of that protein. For this work, we compared healthy blood donors to sarcoidosis patients, and then we also compared different sarcoidosis subtypes. This is somewhat of a complicated way to show our results, but this green circle indicates the number of proteins which were differentially abundant between sarcoidosis versus control comparison. The blue circle is stage 2-3 disease versus remitting disease, and this color is untreated stage 2-3 disease versus stage 0 or 1 sarcoidosis. There were a large number of proteins which differentiated healthy controls from sarcoidosis, 9 of which, shown here, also discriminated stage 2-3 disease from remitting sarcoidosis. 7 proteins which were different in healthy controls versus sarcoidosis comparison also differentiated active pulmonary disease from no pulmonary parenchymal involvement, and those proteins are listed here. And some of the proteins that we found in healthy control versus sarcoid comparison are shown here. For each protein, we show data of their abundance and an ROC curve indicating the sensitivity and specificity of the discriminant power. And some of the proteins, both immune response and metabolic, appear very promising, and we are planning to validate this in a larger data set. However, when we compare sarcoid subtypes, stage 2-3 versus remitting, or stage 2-3 versus 0 and 1, the differences are less striking, which indicates to us that a panel of proteins which will probably be needed to develop models which will differentiate these groups. Here are the conclusions of our work so far. We believe that biological mechanisms of lung disease can be identified by studying bronchoalveolar lavage cells, and some of these are also detected in bronchoalveolar lavage fluid. We provide a framework to develop biomarkers in both BAL fluid and blood to differentiate sarcoidosis from other conditions. The next step would be, instead of healthy controls, to have disease controls as a comparison group. This framework can also be used for sarcoid subtypes. And as future directions, we would want to validate our findings in a larger cohort. Before I end, I would like to thank a number of faculty at University of Minnesota. David Pullman has carried the weight of the clinical program since it was developed and has seen a lot of patients and recruited several of them for the registry. We have a multidisciplinary team of cardiology, rheumatology, immunology, and excellent care coordinators, which help take care of the patients with sarcoidosis. I'm fortunate to have great collaborations at National Jewish Health with Dr. Lisa Meyer and Ohio State University, Dr. Elliot Krauser. I'm thankful to the funders, but above all, I'm most thankful to the patients who allowed us to do the work that I showed you today.
Thank you very much, Manish. Phenomenal work, and I'm sure there are quite a few questions. I said, if I may, I would like to welcome the next speaker, and we'll have the questions at the end of all the talks. It's a great privilege to invite the next speaker, who is actually the leader in this field for decades, who had paved the way for several studies in the field of sarcoidosis. People always say the road less traveled. Dr. Baumann took that path when there were not many therapies available. Several decades ago, he took a deep interest in sarcoidosis and designed several clinical studies to prove the safety and efficacy of different treatment modalities. And he was instrumental in setting up the WASAG, which is all of us are familiar with. And it's indeed a deep honor, and with deep gratitude, I would like to invite Professor Baumann to give his next talk on sarcoidosis, what is in the pipeline. May I have the next talk, please?
Hi, this is Dr. Robert Baumann, and I'm talking today about sarcoidosis treatment update, what is in the pipeline. I do have some pharmaceutical support here for sarcoidosis over the years. I want to acknowledge the various companies that have been involved in helping me here. Today I'm going to be talking about evidence-based guidelines, how they really helped us move forward with the diagnosis and treatment of sarcoidosis, and this in regard to clinical trials that are ongoing. I've been asked to talk about what is in the pipeline. To give a sense of that, you need to realize that there is several ways that we think about treating sarcoidosis. Although there's been a great deal of emphasis on inflammation, lately we've been more concerned about other aspects, especially at end-stage sarcoidosis, such as fibrosis and pulmonary hypertension. The European Respiratory Society did publish evidence-based guidelines about a year and a half ago now. Dominic Valera and I chaired this committee. We did have the opportunity of looking at a strategized approach to taking care of patients with sarcoidosis, which I'm sure will be discussed by various speakers throughout this meeting. But one of the things about this is it gives us things like pharmaceutical companies and investigators an approach to look at where we should be looking at new treatments. Specifically, at this box down here in the bottom corner, patients who have failed corticosteroids, toxicity, and cytotoxic agents, to consider third-line therapies, including drugs such as infliximab, which we've been studying now for more than 15 years, and other agents that may also be useful. And this general group is considered biologics for treatment. In the guidelines we looked at 5 drugs that had enough data that we can make great recommendations. In fact, only one drug had a great recommendation, which is infliximab, but other drugs were felt to be useful on a case-by-case basis and were considered in the guidelines. These include two TNF agents, rituximab, both the JAK2 inhibitors, and RCI, corticotropin injection. This is in stark contrast to other inflammatory diseases such as rheumatoid arthritis. In 2020, there were over 13 new agents available for rheumatoid arthritis, and more are on the pipeline. These have all been FDA approved and well studied in rheumatoid arthritis. One of the limitations in sarcoidosis is certainly volume, and it's also been the failure to identify specific endpoints that the FDA will accept. We are working our way through one of our more successful biologic agents. The average duration of therapy was only about 6 years before we had half the patients had to look for new treatment. This is not unique for sarcoidosis. Almost all conditions, such as rheumatoid arthritis and Crohn's disease, the biologics have a half-life of about 2 to 5 years, depending on the indication. The most common reason for stopping biologics are listed on this slide. Infection and adverse events were significantly more common with the anti-TNF agents, not only things like tuberculosis and fungal infections, but severe bacterial infections. For infliximab, severe allergic reactions are more common with this drug than any other agent, since it's a chimeric monoclonal antibody. Nevertheless, other agents still can be associated with infection, and unfortunately to insurance, because all these agents are costly, can be a reason for discontinuing the agent. Well, in sarcoidosis, the anti-inflammatory pathway, you should think about treatment in two general broad pathways. One is focused therapy, that is a single target, and the other is diffuse therapy, looking at multiple targets and see how the drug works. An argument can be made that focused therapy is neat, it's clean, it's taking things out. And the archetypal example here is infliximab, which is an anti-TNF antibody, and its effect on that cytokine is relatively straightforward, and yet it has a diffuse effect, basically shrinking the granulomas quite effectively. Now, other targeted therapies have been studied, not quite as successfully as infliximab, and others have argued that maybe a more broad-based approach. The cytokine and inflammatory response is so wide, as shown on this slide. There are multiple targets here. So drugs like glucocorticoids, which take out the macrophage and CD4 cell, these are part of the formation of granuloma. So maybe glucocorticoids, such as prednisone, are more effective because they work on multiple targets. This is a strategy behind a drug like, say, ezetimibe, which I'll be talking about a little bit later, that works on both the macrophage and CD4 cell and fibroblasts. This is also targeted for things like mTOR inhibitors and positonic corticosteroid injection, but they have multiple targets. And maybe this will be a more successful form of therapy. Well, I'm going to list here the next 3 slides of various drugs that are being studied or have been recently studied. And I've given an arbitrary red, yellow, and green. Green being that the drugs are successful and currently practiced. Infliximab and ezetimibe clearly fit into the category. And there is a biosimilar that is being studied specifically for sarcoidosis, and hopefully in the next few months that drug will be launched in a phase 3 trial, and we'll have that drug available with commercial insurance paying for it in the United States. Other anti-TNFs such as etanercept and golimumab were failures, and anti-IL-12 has also been a failure. Canara did not work for pulmonary sarcoidosis, is still being studied. Cardiac sarcoidosis and anti-IL-17 is also being studied in Novartis. Rituximab, looking at B-cell, T-cell, but the story is still out on that, but there is no trial looking at the anti-B-cell therapy. Repository corticosteroid injection, as I said, is available in the United States only. It's still undergoing randomized trials, but it's commercially available and it's being used for treatment. I'll talk a little bit about the JAK2 inhibitors, JAK-STAT pathway inhibition. There's been a couple of drugs, apremilast and nifurtimox, that we've studied showing the benefit, especially nifurtimox for fibrotic sarcoidosis, preventing recurrent episodes of bronchitis. Thalidomide originally looked good, but a double-blind placebo-controlled trial for skin lesions did not show benefit, but the endpoint there was controversial. On the side, looking at some of the other agents that are possibly available, the VIP has been studied in the past, and the new trials being planned for this by Miller Quinine. I think they need to see what's going to happen there. Ezetimibe, I'll talk a little bit more about in a minute. Topical nicotine by Elliot Krauser. That was a positive trial, but a very small improvement in force capacity with a lot of toxicity associated with the Nicoderm gum that they used. Placental-derived mesenchymal cells, that was a mixed trial, very expensive, and no further studies are at this time anticipated. mTOR inhibitors and anti-GM-CSF, their clinical trials are ongoing, and I think that we just need more information to make any comment about where these studies go. There really isn't any much preliminary data for each agent. The new companies have elected to move forward with larger trials. Look at efzofitimod. This is a JAK2 inhibitor. There's a suggestion that this is an important pathway in the pathogenesis of sarcoidosis, and this was spurred on by a study from Yale by Dr. Dansky and his group, which showed a marked improvement. It was published in New England Journal of Medicine, and they recently followed up with a study of 10 patients treated for cutaneous sarcoidosis. This is a very impressive paper showing lots of information, showing response to skin lesions, showing steroid sparing, improvement of cytokine response, and all 10 patients with the skin lesions. They did talk about other organ manifestations, but they were not standardly reported, and I'm not really sure how much improvement they saw. Our experience to date is with the JAK2 inhibitors is fairly mild and may not be that successful. They've recently got a black box warning for cardiac disease in the United States, which is going to limit their use for many of our advanced sarcoid patients. These drugs still should be studied. This is an intriguing case. Dominic Bellaire's group in France, a patient who had a mutated polycythemia and therefore was placed on a JAK2 inhibitor, who also had sarcoidosis, and you can see the CT scan at the in the middle panel of the CT shows lots of fluid sarcoidosis, which disappeared with JAK2 inhibitor. This is also the response as far as the skin lesions, as far as the pulmonary function, and the prednisone dosing. Well, as I talked a little bit about before, this is a novel drug that goes along the NERP2 pathway. NERP2 are an inflammasome type pathway, lead to an aberrant immune response, both T cells and antigen presenting cells, and they can lead on to fibrosis and inflammation. AIG, the company that is looking at this drug, has elected to go pretty exclusively for sarcoidosis at this time, and they have shown one small dose escalation trial, which was quite positive. It showed improvement, significant improvement in quality of life. There was a trend for reduction in corticosteroids and forced vital capacity. And as a phase 2 trial, it was felt that with sufficient data, they could move forward to do a double-blind placebo-controlled trial, which has been launched, and patients are currently being enrolled in the United States and Europe for this trial. Well, the anti-inflammatory therapy is, I think, only one part of what we should be looking for. And new drugs are being developed for trying to reduce the morbidity and mortality of sarcoidosis. And there are two potential severe causes of mortality in sarcoidosis. One is pulmonary fibrosis, and the other is pulmonary hypertension. Not only about 5 to 10% of patients with sarcoid die from their disease, but these are the two major reasons they die. So one of the tricks is to try to identify who is going to die. So there have been 3 large surveys that have been published. These are retrospective studies done from London, Paris, and Cincinnati. And one of the factors that can help identify those who are going to die is simply an HRCT. If they have greater than 20% fibrosis, they have an increased risk of about 3 times higher than the general sarcoid population. Another increased risk factor is pulmonary hypertension, whether you do it on the basis of increased pulmonary artery diameter or actually direct right heart catheterization. And again, these are increased risks. Ross's algorithm actually predicts whether pulmonary hypertension or pulmonary fibrosis, and again, all 3 studies showed an increased risk. And these are the ones with stars and markers, which are independent risk factors. So these do point out that there are 2 factors, pulmonary hypertension and pulmonary fibrosis, that we should be considering treatment. Recently, a panel led by Mark Humbert, myself, and Athol Wells came up with suggested recommendations how to manage sarcoid-associated pulmonary hypertension. And one of the issues is that once we identified that this is on the basis of vascular disease, to consider specific therapy. This is in fact been done. There's an endothelin receptor antagonist, bocetin, that has been shown to reduce pulmonary hypertension compared to placebo. And also, we have been in now a double-blind placebo-controlled trial looking at time to clinical worsening. The study was of rheumatological. Unfortunately, the study was prematurely discontinued because of COVID. We only were able to enroll 17 patients, and 16 patients were randomized, 8 to receive drug, 8 to receive placebo. The primary endpoint of the study predefined was time to clinical worsening based on death, bone transplantation, or greater than 50-meter drop in 6-minute walk distance. And if you look at what happened here, is those patients on placebo, about half of them had time to clinical worsening, whereas in the Rheumatological record, none of them had time to clinical worsening. 2 of the patients had transplant or death, 2 of them had 6-meter, 50-meter walk distance. So these are patients that were getting worse when they stabilized. In fact, they were getting better if you looked at 6-minute walk distance. There was a significant difference in the change in 6-minute walk distance. For riociguat was going up and for placebo was going down. The study was, as I said, prematurely discontinued, and at this point, no further studies with riociguat are being studied, but other agents, selexipag and inhaled treprostinil, are being studied for sarcoid-associated pulmonary hypertension. And I think these larger trials should give us more insight into what's happening with these patients and whether we can change their clinical outcome, such as suggested by this smaller trial. Well, what about fibrosis? Again, about 5 to 10% of patients with sarcoid die from fibrosis in their lungs. It occurs in about 20% of patients with therapy. Well, a patient with fibrotic sarcoidosis, the first thing you need to determine is whether they would still benefit from anti-inflammatory therapy. The PET scan, if positive, should be treated. Beyond that, though, there are 2 potential agents that have been well used in idiopathic pulmonary fibrosis and been discussed and treated in patients with progressive pulmonary fibrosis. Nintedanib has been most widely studied, and the INVAIL trial has led to approval of this drug for progressive pulmonary fibrosis, including sarcoid pulmonary hypertension. Unfortunately, the INVAIL trial only had a total of 9 patients, 3 of whom received active drug for pulmonary sarcoidosis. For pirfenidone, we had independently been studying this drug for fibrotic sarcoidosis. A study Adler Wells and I did. The study, because of technical problems, mostly led to Brexit, was only done in the United States. And these are the 3 centers that participated in the United States. Again, we were stymied by COVID. But what we were looking at in this trial was time to clinical worsening. And the time to clinical worsening in this 18-month trial was predefined again by death or lung transplantation. And in this case, we used forced vital capacity of greater than 20%, 10%. You can see of the total of 16 patients that we studied, 25% had one of these time to clinical worsening events. So I think we identified a population. To get into the study, the patients had to have at least 20% fibrosis on HRCT. As far as pirfenidone was concerned, unfortunately, there were more patients who had clinical worsening were in pirfenidone than placebo, but only 5 patients were treated with placebo. And this difference, the time to clinical worsening, although it's striking on the graph, was not statistically significant. The study was planned to enroll 60 patients and again stopped because of COVID. We did an exploratory analysis to see whether there was another factor that could be identified beyond just HRCT, and we went back to DLCO. And by doing multiple different cutoff points, we identified that if greater than less than 30% vital capacity, that identified all our patients. And I think that vital capacity, probably not as successful as DLCO, with the addition of fibrosis on HRCT, should be used as a criterion in future trials. So in conclusion, new treatments are being studied for sarcoidosis. These are looking at not only inflammation, but also looking at fibrosis and pulmonary hypertension. For inflammation, the trials that I think that are most interesting right now include efacitamide, nilotinib, mTOR inhibitors, and JAK2 inhibitors. I do not include the biologic equivalent for infliximab, although that is also being studied, and I think that that will provide us information. That's because I think in a lot of ways the infliximab biologic that is about to be launched will give us the same results that we see with infliximab, hopefully with less toxicity, and will just be another drug for us to use. As far as treatment for sarcoid-associated pulmonary hypertension, I think that previous trials and case reports have suggest some improvement with various agents, but we really need large multi-center trials, a couple of which are ongoing. And treatment for sarcoid-associated pulmonary hypertension and fibrosis has the same limitation that you need to have larger numbers, and you can't just do it in single institutions. I want to stop at this time and take any questions from the audience. Thank you very much for your attention.
Thank you very much, Dr. Beaumont. It's an exhaustive, truly what is in the pipeline. There seems to be a lot of candidate molecules which are being evaluated. We have about 10 minutes for questions and answers. and any interaction, any questions to the previous speaker.
My question is to Dr. Durga Prasanna. Do you think there needs to be a constant environmental trigger in a genetically susceptible individual, or a one-time point exposure to the environmental trigger would produce the phenotype?
Thank you, sir, for this very interesting question. In the data that I had reviewed, the World Trade Center firefighters, when they looked at the clinical data, there appeared to be a dose response curve, that is, a greater degree of exposure appeared to predispose a greater risk of developing the disease. But when they looked at the genes and they attempted to look at interaction between the gene and the dose of exposure, they could not really get this association. So what they concluded was that one of the hypotheses generated from that was the exposure to the dust rather than the duration of exposure was what triggered. Other studies have suggested different things. For example, household smoke arising from wood burning and other things, there is a dose response curve. That is, a greater dose is associated with a greater risk. So again, information on this is scant, and we really can't have a definitive conclusion.
Thank you very much. This is from Dr. Shomu, who's leading a lot of work in cardiac sarcoidosis, to Dr. Cron. Has the group established standard evaluation criteria for first diagnosed sarcoid of any type and minimal investigations that are done to find out other organ involvement? It's rather a minimalistic approach. What are the screening tests to pick up other organ involvement? I think they have published it. Anyway, I'll let Dr. Cron address this question.
This is regarding clinical diagnosis of cardiac sarcoidosis?
That's right. That's right.
Okay. Yeah, so there's several different strategies to diagnose cardiac sarcoidosis. Clearly, the most reliable is the cardiac biopsy. But, you know, that has some risk with it. There's a risk of perforation in patients, particularly who've never had prior surgery or transplant. So, you know, most of the diagnostic schemes have a secondary approach, which is diagnosis in another organ system by biopsy and then clinical features, imaging features that suggest cardiac involvement. So probably the most commonly used one is the Heart Rhythm 2014 guidelines. I think they're very reasonable. There's both the myocardial biopsy and then extra cardiac biopsy, typically lymph nodes, skin, or liver, and then clinical and imaging features that support that. So having an MRI that shows late gadolinium enhancement, having clinical features such as complete heart block or ventricular arrhythmias. We actually have some data that we have presented and is currently in submission, looking at the HRS diagnostic schemes compared with the Japanese, diagnostic schemes that have been amended over the years. And what our findings are, and this was not for diagnosis, this is for outcomes. But overall, we looked at these diagnostic schemes in our consortium. What we see is that the heart rhythm diagnostic schemes tend to be more forgiving. They pick up more patients. So I think that for the clinical diagnosis, probably using the heart rhythm are the best ones clinically to try to identify your patients. The Japanese diagnostic criteria are a little more stringent. You often have to meet more than one clinical criteria. So it probably picks up patients with either more severe disease or more progressive disease or more severe phenotype. So probably the heart rhythm ones are the most clinical.
In our sarcoid clinic. Dr. Vishwanath, please.
So my question is to Dr. Manish actually. Thank you very much for your wonderful talk. So you have mentioned about proteomics and different important pathways in progressive pulmonary sarcoidosis. Here in our country, tuberculosis being a very important problem and often confusing with sarcoidosis. Lot of cases we are able to differentiate with probably the gene expert which is currently available with us, and also sometimes the kind of presentation, looking at the clinical presentation, we tend to see whether it's sarcoidosis or tuberculosis, and also the radiological presentation. in spite of all of these clinical, radiological, and microbiological tests, sometimes we are left with a few of the patients actually whom we have a confusion about what is the diagnosis, whether it's tuberculosis versus sarcoidosis. Do you think in these kind of patients, doing a proteomic analysis would be helpful? Or are you aware of any other studies which are ongoing which would help in differentiating between TB versus sarcoidosis, the proteomics one?
Got it. Manish?
Yeah. So that's actually a great question. You know, if you kind of look at how we define sarcoidosis, still it is a diagnosis of exclusion, which means that we have to rule out everything else which could look like sarcoidosis. And just by that fact, you can never be 100% sure whether that is what you're dealing with. And Dr. Bachman might have some ideas about it, but Dr. Judson, who's at Albany, has published about it. But then the question is, moving forwards, can we develop tools which can differentiate things which look very much like sarcoidosis in the US? Histoplasma is that challenge, that, you know, it mimics sarcoidosis exactly. And that is what we're trying to do. When I say that we want to move our work to disease controls, those are the controls which we want to study to see if we can develop a model which will differentiate sarcoidosis from TB, from histo, and from other similar things, you know, sarcoid reaction from drugs and cancers, etc. But as of now, sarcoidosis remains a diagnosis of exclusion.
Thank you very much, Manish. I think I would like, this is a very, very pertinent question for us because we face this problem day in and day out. And I would like any one of the panelists or Dr. Bachman, do you have any thoughts on what should be our approach to this?
Yeah, thank you. I think that the approach we've been taking is a slightly different pathway. I think the proteomics is an interesting question, but what we have developed was we call a sarcoid diagnostic scoring system, and which we started off in Cincinnati. And the idea is that organ involvement, the more organ involvement, the more comfortable you are with the diagnosis. And we just completed a multinational trial of nearly 3,000 patients across the world, including India, China, Eastern Europe, so that we had a large cohort of tuberculosis cases as comparator groups, malignancy, many of the things that you see coming in versus sarcoidosis. And we were actually able to distinguish pretty well on clinical criteria between TB, for example, and sarcoidosis. And I do think that I also worked with several of you in India about diagnosis of sarcoidosis and treatment in endemic areas for TB, such as in India. So I think if you use clinical criteria, the more organ involvement. And I think Dr. Krohn points out that the same thing happens with cardiac disease. If you have somebody with known sarcoidosis, then that imaging technique becomes a lot more useful. I think the difficulty is when you have somebody